Hello guys, I am Dr. Navneeth. Today we are going to start with our second part of the rapid revision. In the first part, we have already talked about the conceptual topics, so the second part is going to be easier. It is mostly about systemic pharma. So the first chapter is respiratory system here, and we are going to talk about the bronchial asthma. Now, what is bronchial asthma? It is a chronic inflammatory airway disorder. It is a chronic inflammatory airway disorder with reversible bronchoconstriction. That means the bronchoconstriction can be reversed. So here you have to treat things. One is the bronchoconstriction and the second one is inflammation. So this is going to be the aim of our treatment. Now, bronchial asthma is a type 1 hypersensitivity reaction. Why? Because it is an allergy. Now, how is this allergy happening? Whenever there is first exposure to the allergen, this allergen is picked up by an antigen presenting cell. It has an MHC that will show this allergen to the T helper 2 cell. Now, what will this T helper 2 cell do? This will release interleukin 4, interleukin 5 and interleukin 13. Interleukin 4 will bind to the interleukin 4 receptor. Yes, this interleukin 4 receptor is present on the B cells. Now, it will do something known as isotype switching. What does this mean? See, B cells already have IgM and D on the surface. These are antibodies. You know, B cells will produce the antibodies. They already have M and D on top of them. Now, it will be converted into other classes of the antibodies. That is why it is known as isotype switching or class switching. Yes. Now, what is important here is whenever this allergen comes, it will release IgE. It will release IgE. We have all these antibodies G, A, M, D, E. Yes, it already has M and D. It will produce G, A and E. Here IgE is important. This IgE will go and bind on the mast cell. Okay. This will sensitize the mast cell. Now, how is this IgE attached on the mast cell? It will sit here very nicely. Yes. So, you can see here, this is how IgE is going to be attached on the mast cell. So, this is what has happened during the first exposure. Yes. Now, this IL-5 will activate eosinophils. It is given in the name itself. 5 means fifth alphabet, that is E. It is eosinophil. IL-13 will increase the mucus production. It will increase the mucus production. This is what is going to happen in the first exposure. Now, in the second exposure, when this same allergen comes, the mast cell is already sensitized. That means it already has IgE antibodies on top of the mast cell. Now, what will this allergen do? This allergen will sit in between this antibodies and it will cause degranulation of the mast cell. Once the mast cell is degranulated, it is going to release histamines, prostaglandins and leukotrienes. Now, what is histamine doing? All of you know it will cause inflammation and bronchoconstriction. What is prostaglandin doing? It will also cause inflammation. What are leukotrienes doing? It will also cause bronchoconstriction. But what is important, you have gotten your aims of treatment. How are you going to treat it? See here, I told you, you have to first treat the inflammation here. Yes. How can you treat the inflammation? Obviously, the best drug for inflammation is always steroids. Yes, but steroids are very toxic. So here you will give inhaled corticosteroids. That is how you are treating the inflammation. So this is the first class. Now, how can you treat the bronchoconstriction? By bronchodilators. What are the bronchodilators that we have studied? But what is the best bronchodilator in bronchial asthma? It is going to be beta-2 agonist. We have studied SAMA, LABA, VLABA. Yes, SABA, LABA and VLABA. Got it? Now, next is coming to be muscarinic antagonist. That also we have studied, if you remember. SAMA, IMA and LAMA. Yes, ipratropium, thiotropium, all of these. Now, we also have one more drug that is also known as theophylline. That is also known as theophylline. If you remember, I told you a point about theophylline in the general pharma. Erythromycin is a enzyme inhibitor. When you give erythromycin along with theophylline, it will cause theophylline toxicity. This is what I asked you to remember. Yes. Now, so these are the 4 classes of drug. We are finished with the 4 classes of drug with inflammation and with bronchoconstriction. Now, if you see here, leukotrienes will act on leukotriene receptors. Leukotriene will act on leukotriene receptors. So, we can give a drug called leukotriene receptor antagonist. Leukotriene receptor antagonist. These are what are known as what? These are the drugs that you commonly take: montelukast and zafirlukast. So these are all the classes of drugs. Now, if you go a bit further, you can see here, because of mast cell degranulation, all of this is happening. So you can also give mast cell stabilizers. Mast cell stabilizers. If you block it from degranulation, obviously you can treat it. Yes. So these are what are cromolyn sodium drugs. Yes, this is mast cell stabilizer. Now, if nothing works, we are going to give monoclonal antibodies. Monoclonal antibodies. Now, how can you remember these monoclonal antibodies? It is IL-4 or IL-7 or what is it? That is why I told you all of this pathology, so that your pathology is covered and your pharma and medicine will also be covered from this one single diagram. So, if you see here, IgE is acting, IgE is binding to the mast cell. So, you can give an antibody, monoclonal antibody against this IgE, that is what is known as omalizumab. Omalizumab. Now, IL-4 is binding to the IL-4 receptor, so you can give an antibody against the IL-4 receptor. Against the IL-4 receptor, this is what is known as dupilumab. This is what is known as dupilumab. Now, IL-5 is again acting on IL-5 receptor on eosinophil. You can also block this IL-5 receptor by giving benralizumab. Benralizumab. Did you understand? So these are all the important monoclonal antibodies: omalizumab, dupilumab and benralizumab. Now there is also one more against IL-5, that is mepolizumab. Mepolizumab. So all of these are monoclonal antibodies. It is given in the name, monoclonal antibodies. So this is how you can remember all the drugs in the bronchial asthma without any mnemonics. How did you remember it? With the help of pathology. So I told you in the first exposure, it is going to Th2 cell. It will release IL-4, IL-5, IL-13. IL-4 will cause class switching. It will release IgE. IgE will bind to the mast cells. Now, when there is second exposure, there is degranulation. Mast cells will release prostaglandins, histamines and leukotrienes. So, what are the drugs? First, there is inflammation. So, inhaled corticosteroids. Now, there is bronchoconstriction. So, you are giving bronchodilators like beta-2 agonists and SAMA, IMA, LAMA, muscarinic antagonists and theophylline. These are the first 4 classes. Then there is leukotriene. So, there you will give leukotriene receptor antagonist. Now, you can also stabilize the mast cell. So, you can give mast cell stabilizers. Next are monoclonal antibodies: omalizumab, dupilumab, benralizumab and mepolizumab. These are all the classes of drugs in the bronchial asthma. Now, what are important points here? Inhaled corticosteroids means obviously you are taking it through inhalation. When you take steroids through inhalation, example budesonide, cyclosonide, if you are taking this through inhalation, it might cause hoarseness of voice. So this is one of the side effects, hoarseness of voice, and it will also cause oral candidiasis. Oral candidiasis. Why? Because steroids will decrease the immunity, so it will cause fungal infections on the tongue. This is what is oral candidiasis. Now the most important question that has been asked here is, how do you prevent it? You prevent it by using a equipment that is known as spacer. So when you keep a spacer, in between the inhaler and your mouth, this steroids are getting deposited directly into the lungs. It will not stay in the mouth, so it will not cause candidiasis. This is what is important. This is a very, very important question. Yes, this is about ICS. Beta-2 agonist, muscarinic antagonist, that you have already studied in the first chapter itself. Now, theophylline, I asked you to remember when it is given along with a enzyme inhibitor. enzyme inhibitor, that is erythromycin or clarithromycin. This is what the questions are usually asking. What do you see the side effects with these? Is toxicity of theophylline. What do you see in toxicity of theophylline? Mostly it will cause arrhythmia and it will also cause seizures or epilepsy. This is what I want you to remember. This is what you see in theophylline toxicity. Leukotriene antagonist, I have already told you. So that's all about the drugs in bronchial asthma. So now coming to the second chapter, that is the drugs for cough. We have two kinds of cough, dry cough and productive cough. In dry cough, there is no sputum. You're just coughing because there is some kind of irritation. So how do you treat it? You treat it by giving antitussives. Why? Antitussives will suppress the cough center, so you will not cough. That's all, treated. Now coming to the productive cough. Productive cough means there is some kind of sputum inside and you're coughing so that the sputum comes out and the infection is relieved. Now let us suppose if you are using antitussives here, then you will stop coughing, the sputum will stay inside, it will build up and it will cause infections. So antitussives are never used here. So what will you use? You will use expectorants and mucolytics. What will mucolytics do? Mucolytics will break down the sputum, make it easier for the sputum to come out. What will expectorants do? Yes, it is throwing the mucus outside. This is what you going to study in productive cough. Now you have to remember few names. We will see central antitussives, they are suppressing the cough center. In this we have two kinds of drugs. One is opioids and non-opioids. Opioids are codeine, folcodeine. You can see ethyl morphine, morphine, methadone. Yes, side effects is addiction. It will cause addiction. That is the reason why in the general practice you don't see codeine, folcodeine and ethyl morphine. You generally see the non-opioids being used. That is what is dextromethorphan. Dextromethorphan. This is generally used in the central antitussives. Now coming to these peripheral antitussives, they act on the lungs. Yes, so the signal has to come from the lungs into the brain. So if you are blocking it at the level of lungs, that is what is peripheral antitussives. There are local anesthetics like lidocaine and mexiletine, we never use them, and moguistine and prenoxidazine also not being used. Now commonly we are using the dextromethorphan. Now coming to the expectorants, guaifenesin is the most important expectorant that I want you to remember. I told you it will cause bronchial contraction, so the sputum comes out easily. Mucolytics means it will break down the sputum, so it becomes easy for the sputum to come out. It is ambroxol and bromhexidine That's all. This is what I want you to remember. Now there are so many cysteines that you can remember if you want: acetylcysteine, carbocystine, iridocysteine. All of these are also mucolytics, but important ones are ambroxol and bromhexidine. This is what you see in the syrups. Now coming to the pulmonary artery hypertension, important topic in medicine. Basically it means there is increased blood pressure in the pulmonary artery. How much is it? Different textbooks say different values. Some say it is more than 20, some say it is more than 21. So it is either more than 20 or 21 mm Hg at rest in the pulmonary artery when you are measuring it with the help of right heart catheterization. Now what is the most common for this? You don't know. It is idiopathic. But what did the scientists find out is, when do you have hypertension? You have hypertension when there is vasoconstriction. If there is a lot of vasoconstriction, it will increase the blood pressure. Yes, so that is what scientists have figured out. Those people are saying there is increased vasoconstriction and decreased vasodilation. Now, how is the vasoconstriction increased? It is releasing a material known as endothelin. Yes, endothelin will cause vasoconstriction. Now, we have vasodilatory factors in the blood vessel as well. These are PGI2, that is prostaglandin I2 analogs. We've already talked about this in the autocoids chapter. Yes. Now, it will also decrease nitric oxide. Nitric oxide is a potent vasodilator, so it is decreasing both PGI2 and nitric oxide. This is the reason. Now, how can you treat it? You decrease the endothelin and you increase the prostaglandin I2 and nitric oxide. This is the treatment. That's all. This is why I told you all of this. Okay. So we are going to see First, whenever there is vasoconstriction, you always try out with the calcium channel blockers here, that is nifedipine. So you can remember first class of drug is nifedipine. Now, once you're done with this, now we are going to come with the main classes of drugs. I told you it is increase in endothelin. How do you decrease it? By giving endothelin antagonist. Okay. So these are ambrisentan and bosentan These are endothelin antagonist. That means it is blocking the endothelin receptors. That's all. Now coming to the PGI2 analogs. So it is analog of prostaglandin I2. We've already talked about it in the autocoagulants chapter. What are they? Eloprost, epoprostenil and trepoprostenil and trepoprostenil. Yes, that's all. So these are prostaglandins. That is why you can see the name prost in them. Did you understand? Now there is a PGI2 agonist as well. That means this will act directly on the PGI2 receptor. What is this? It is selexipag. It is selexipag. Yes. Now after this we will talk about the nitric oxide. You can give nitric oxide as a continuous inhalation. Yes, you can give it as a continuous inhalation, but it is not used these days. But we will see how nitric oxide is working. Yes, nitric oxide will activate guanylyl cyclase, and this guanylyl cyclase is increasing the cyclic GMP. This cyclic GMP will cause vasodilation. Yes, so basically nitric oxide, cyclic GMP, vasodilation. Okay, so if you see here, first thing, if you are activating the guanylyl cyclase, will all of this happen? Yes, it will happen. Okay, so that is why we have made a drug called riociguat. We have made a drug called riociguat. So guat means guanylyl cyclase stimulator. Did you understand this much? Guanylyl cyclase stimulator, that is riociguat. Now coming to the PDE5 inhibitors. If you see carefully, cyclic GMP is metabolized. Cyclic GMP is metabolized by PDE5. So if you block this metabolism, cyclic GMP will increase. How can you block this metabolism? By giving PDE5 inhibitor. This is what is sildenafil and tadalafil. So that's all. These are the classes of drugs that you use in pulmonary artery hypertension. I hope you understood the chapter on respiratory system. This is what is important for the exam. Now we are going to start with the cardiovascular system. The first chapter is vasodilators. As you know, vasodilators are going to decrease the BP. I told you vasoconstriction will increase the BP, so dilators will decrease the BP. Now we have three kinds of vasodilators because we have different vessels in the body. If it is dilating the arteries, they are known as arterial dilators. If it is dilating the veins, venous dilators. If it is dilating both of them, these are mixed dilators. So if you are causing arterial dilation, it will decrease the afterload. Easy to remember, A for A. If it is dilating the veins, it will decrease the preload. Now, whenever this decreases preload, it causes a side effect that is known as postural hypotension. It causes something known as postural hypotension. Even mixed will decrease both preload and afterload because it is dilating both arteries and veins. So here also you will have the side effect of postural hypotension. Why? Because there is venous dilation. Now let us see what are the examples of arterial dilators. These are potassium channel openers. You can see here calcium channel blockers and phenol-dopam. In autonomic nervous system, we have already studied. Phenol-dopam is not so important for us in the autonomic nervous system. So we are going to start with the potassium channel openers and the calcium channel blockers. Now in the venous, we have only nitrates that we need to study. In the mixed, there are RAS inhibitors and sodium nitroprusside. Sodium nitroprusside, I will talk about it in the hypertension chapter. Why? Basically because it is decreasing the BP, so it can be used in the treatment of hypertension. Starting with the potassium channel openers, you can remember with the name of MDH. Yes, MDH, minoxidil diazoxide and hydralazine. Yes, minoxidil is used for hair loss. It is used topically for androgenetic alopecia. Side effect is going to be, what is the use first? I already told you, it is androgenetic alopecia. You're using it. It is a cutaneous vasodilator, so it will increase the blood supply and it will decrease the hair loss. Yes, it will decrease the hair thinning also. Now, what would be the side effect? It will cause unwanted hair growth, that is hirsutism. Now, coming to the diazoxide. This is drug of choice for a tumor known as insulinoma. Why you need potassium channel blockade to release insulin? But if you are opening the potassium channels, what will happen? Insulin will not be released, so insulin release is decreased. That is why it is used in insulinoma. Yes, now coming to the hydralazine. Hydralazine can also be used for hypertension. I am going to talk about this in the hypertension chapter, but what is the side effect? I told you in the general pharmacology, it is going to cause drug-induced SLE. So what are the drugs that will cause drug-induced SLE? It is SHIP drugs. So H is for hydralazine, SHIP drugs, D is for dapsone. Yes, this happens in slow acetylators. I also told you the reason why. Now, coming to the calcium channel blockers, we have two types of calcium channel blockers. These are DHPs and non-DHP. DHP means dihydropyridines and the other one is non-DHPs. Now, DHPs are very easy. These are having dipins in their name. Yes, DHP dipins, rhyming, easy to remember. You can see here nifedipine, nicardipine, clebidipine, nimodipine, all of these. Now, if you see nimodipine is cerebroselective. That means it works well in the cerebral vessels. So it can be used. It can be used in subarachnoid hemorrhage or intracranial hemorrhage whenever there is vasoconstriction that is causing ischemia. So to prevent this from happening, we can use something known as nimodipine. This is a very important MCQ. This is what I want you to remember. Now coming to the non-DHPs. Non-DHPs will also block SA node and AV node along with vasodilation. SA node and AV node is also blocked. So what might happen? It might decrease the heart rate or it might keep the heart rate normal. Why am I talking about this? See, dipines are vasodilators. When BP is decreased, there is reflex tachycardia. Okay. Non-DHPs, when BP is decreased, there should be a reflex tachycardia as well, but since we are blocking SA node and AV node, it might keep the heart rate normal or decrease it. Yes. So, what I want you to remember, there are two drugs, verapamil and diltiazem. Since it is decreasing the heart rate, you should never give it with beta blockers. Yes, beta blockers will decrease the heart rate. If you are giving non-DHPs, it will also decrease the heart rate. It will cause a lot of bradycardia. So that is not good for the person. That is why non-DHP and beta blockers are avoided together because of marked bradycardia, because there is a lot of bradycardia. This is what I want you to understand. Now, coming to the nitrates. These are venous dilators, so it will cause postural hypotension because it decreases the preload. I've told all of this. Nitrates are having high first pass metabolism. I've told you in the absorption chapter, when there is high first pass metabolism, bioavailability decreases. That is why I told you seriously nitrates have large first pass metabolism. That is the mnemonic, remember. So this is the reason why whenever a person is having anginal attack, you give nitrates sublingually. Yes, you'll give it sublingually. So when you give it sublingually, it will be directly absorbed into the systemic circulation without going through the liver. That is why we give it sublingually during an acute attack. Yes, but if you want to give it for prophylaxis, you will give it in oral doses but at higher doses because it is having high first pass metabolism. I want you to remember this. You can remember these drug names IDN, IMN, isosorbide dinitrate, isosorbide mononitrate. Yes, these drugs are used commonly. Now, coming to the side effects of this, what is important? The side effects are, it will cause headache, postural hypotension, I've already told you, and then there is something known as Monday's disease. This is what is seen in nitrate industry workers. It is what is seen in nitrate industry workers. Okay, this is very important. Monday's disease. Why? Because they're having continuous nitrate exposure from Monday to Friday. Yes. So usually what happens by the end of the week, these nitrates, the enzyme that are releasing the nitric oxide from the nitrates are utilized, and it will have nitrate tolerance. So the person will not have any symptoms by the end of the week. But once they take a rest or a holiday on Saturday or Sunday, what will happen? These enzymes will start working again. Suddenly on Monday, this nitric oxide will be released and it will cause headache. This is what is known as nitrate. This is what you see in the nitrate industry workers. This is what is known as Monday's disease. So I am saying that there is a nitrate tolerance as well. So if you are giving a tablets in a person daily, it will cause nitrate tolerance. So how can you prevent this? You at least have to keep 8 to 6 hour drug free period to prevent this. This is what you can see. Now after the side effects, where is it contraindicated? See, nitrates are contraindicated with PDE5 inhibitors. This is very important. PDE5 inhibitors. What are these PDE5 inhibitors? I've already told you before. It is sildenafil and tadalafil. If you understand from the before, I told you nitrates will release nitric oxide. Now what will nitric oxide do? It will activate the guanylyl cyclase, it will activate the cyclic AMP. This will cause the vasodilation. Now if you give sildenafil, what will it do? It will block this PDE5, it will increase the cyclic AMP, and it will increase the vasodilation, and it will cause a lot of vasodilation. The person will go into shock. Which shock? Hypotensive shock. That is the reason why we should not use it together. These are very, very important MCQs that have been asked previously. Okay. Please remember, non-DHPs are contraindicated along with beta blockers. Nitrates are contraindicated along with PDE5 inhibitors. This is what I want you to remember, along with the nimodipine. Insulinoma, what is the drug of choice? This is diazoxide. Now, what is left out? Sodium nitroprusside. Yes, this is a mixed one. Now it is used in hypertension, but the most important one that I want you to remember is sodium nitroprusside will cause a side effect of a cyanide toxicity. It will cause cyanide toxicity. It is also photosensitive. That means if you give it in the light, this drug will be broken down. So what you do, you cover it with a dark papers or a dark cover, and then you give the IV injection. That is what is sodium nitroprusside. Yes, in the forensic you must have studied the antidote for cyanide poisoning. This is hydroxycobalamin. If hydroxycobalamin is not there, you can give Lilly's antidote. What is Lilly's antidote? It is nitrites and sodium thiosulfate. Yes, please revise it from the forensic. Okay. Now coming to the second chapter, this is anti-hypertensives. So when a person is having hypertension, how will you treat this hypertension? You tell me, how will you treat this hypertension? First, for the treatment, you should ask him for lifestyle modifications. Diet, exercise for at least 3 months, and when then there is no improvement, then you'll go for the drugs. Now in the drugs, which drugs can be used for hypertension? We have ABCD drugs. Yes, A for ACE inhibitor or ARB, B for beta blocker, C for calcium channel blocker, D for diuretics. These are all the drugs that we have. Okay. Now we are not using beta blockers anymore as a first line these days. So beta blockers are out. These are not used as first line. They are used only if there are some indications that I will tell you in some time. Okay. Start always with 2 drugs. What can be these? They are telling you to start either with A plus C or A plus D. What do you mean by A plus C? A plus C means ACE inhibitors or ARB along with the calcium channel blocker. You will give a long acting oral calcium channel blocker, obviously, because it is for the treatment. No, so you will give amlodip. That is what is being used in the practice, but the guidelines are saying benidipine is better. Now coming to the diuretics, we use thiazide diuretic. So in the textbook it is written chlorthalidone, but the guidelines are saying indapamide is better. Indapamide is better. They are saying that it has lesser side effects, lesser metabolic side effects. You know what are these metabolic side effects about the thiazides I'm talking about? Hyperuricemia, hyperglycemia, dyslipidemia, all of them you see. Yes. Now, this is what are the drugs we are using, either A plus C or A plus D. Now, even after 6 months with 2 drugs, if this is not improving, we have to give all the 3 drugs together. Okay, even after 6 months, if it is not reducing with these 3 drugs, then you will have a doubt. What is the problem? Is the person having secondary hypertension? Look for secondary hypertension. If not, then look for non-compliance. Non-compliance means the patient might not be taking any of these tablets, or he might be taking 1 or 2. Yes. If the patient is still compliant and if the BP is not reduced, if he doesn't have secondary hypertension, this is what is known as resistant hypertension. Now, what is the drug of choice for this resistant hypertension? This is going to be spironolactone. Drug of choice for resistant hypertension is spironolactone. If you remember, spironolactone is a potassium sparing diuretic. Yes, this is what we have studied. It is an aldosterone antagonist, so it will cause hyperkalemia. Now, coming to the drugs. Yes, ACE inhibitors. What is it ending with? All of them are prils. Captopril, lisinopril, enalapril. ARBs, these are sartans. Telmisartan, losartan, valsartan, and azilsartan and olmesartan. Yes, all of this will have a side effect of hyperkalemia. Why is it having hyperkalemia? Pretty easy to remember. I told you, see, ACE inhibitors, this will block renin angiotensin aldosterone system. So if you are blocking this aldosterone, I told you it will cause hyperkalemia. That is why you see hyperkalemia in both of them. But in ACE inhibitors, you have an extra side effect like cough and angioedema. Because when you're blocking the ACE enzyme, bradykinin will increase, and this bradykinin will cause cough and angioedema. So if you don't want this dry cough and angioedema, you're going to use ARBs. Did you understand this? Yes. Now, what are going to be the contraindications in these drugs? Okay, what are the contraindications? These are teratogenic drugs. So, can you use them in pregnancy? No, obviously. These are contraindicated in pregnancy. And also bilateral renal artery stenosis. You cannot use them. Bilateral renal artery stenosis. You can use them in unilateral renal artery stenosis, but not in bilateral. It is contraindicated. So remember this. Contraindications are pregnancy and bilateral renal artery stenosis. Now, why am I not telling you the uses? Because all of the uses of the tablets are given in this one table. You remember this, you will know all the hypertension. Now, what is the best drug for hypertension with diabetes mellitus, nephropathy, stroke, retinopathy, and scleroderma renal crisis? These are ACE inhibitors or ARBs. Why it is nephroprotective? It is protective from the diabetes. It is protecting the retinopathy. So all of these conditions, these are target organ damages. What are you using? It is ACE inhibitor or ARB. Now, if a person has bilateral renal artery stenosis, I am telling you cannot use ACE inhibitor. So what will you use? You will see here. If a person has Raynaud's disease, bilateral renal artery stenosis, isolated systolic hypertension, the drug is going to be calcium channel blocker. Now, coming to the important one, if a person has stable angina, HCM, that is hypertrophic cardiomyopathy, hyperthyroidism, and migraine, the drug of choice is going to be beta blocker. Now you tell me, what is the drug of choice for migraine prophylaxis? Yes, it is propranolol. We've already studied this in Autocoids. Yes. Now, if a person has hypertension with BPH, I already told you which blocker, alpha blockers. Which alpha blocker? Alpha 1 blocker. What is it? It is prazosin. Let us suppose if a person doesn't have hypertension, then you give silodosin or tamsulosin. This is what we have studied. That is why I told you it also causes postural hypotension. Now, hypertension with hyperaldosteronism. Now, hyperaldosteronism means aldosterone levels are increased. So, you have to give an aldosterone antagonist. So, the answer is going to be spironolactone. Why? Spironolactone is also a diuretic. So, it will decrease the blood pressure, isn't it? Now, cheese reaction, all of you know, told you so many times, this is going to be IV phentolamine. Yes. Now, pheochromocytoma, I told you how long the name is, the drug name is almost similar. It is going to be phenoxybenzamine. It is going to be phenoxybenzamine. Next, coming to the osteoporosis, if you remember in the diuretics chapter, I told you thiazides will absorb the calcium, so it will cause hypercalcemia. Isn't it good for osteoporosis? It is decreasing the BP, increasing the calcium. So that is why thiazide diuretics are good for hypertension with osteoporosis. Now, if a person has hypertension with postmenopausal hot flushes, you can use clonidine. Yes. Now, we'll talk about emergencies. Yes, there is something known as hypertensive crisis. When do you have hypertensive crisis? When the BP is more than 180 by 120, that is what is hypertensive crisis. If there is no target organ damage associated with this, that is what is known as hypertensive emergency. There is no target organ damage. But if there is target organ damage, then we call it hypertensive emergency. Emergency means target organ damage is present. Urgency means there is no target organ damage. Now, what is the drug of choice here? Drug of choice for urgency is clonidipine or nifedipine, oral tablets you can give. But emergency, there is target organ damage. You have to give IV drugs like IV nicardipine. This is a calcium channel blocker. Yes, if this is not available, then you can use something known as IV nitroprusside. This is what I told you. This is a mixed dilator. It will cause cyanide toxicity. The antidote is hydroxycobalamin. So that is what IV nicardipine. If it is not available, IV nitroprusside. That is for hypertensive emergency. But what about hypertensive emergency in pregnancy? In pregnancy, you cannot use this drug. The best one is IV labetalol. If this is not available, then you can use hydralazine. This is why I told you I'll talk about the hydralazine in the hypertension chapter. Yes, hydralazine can be used in the pregnancy. This is what I want you to remember. Hypertensive emergency, this table is pretty important. So you can remember in normal people, that means non-pregnant people, or you can write non-pregnant people. What are the drugs? It is nicardipine and nitroprusside. See, N for N. Nicardipine, nitroprusside, non-pregnant. For pregnant, it is labetalol, hydralazine, labetalol. Lol is there. It is a beta blocker. Okay. Now, what about hypertension in pregnancy? Normal hypertension. There is something known as chronic hypertension and pregnancy-induced hypertension. Chronic hypertension means female is already having hypertension and she became pregnant. Pregnancy-induced hypertension means pregnancy has caused the hypertension. Now, in chronic hypertension, you can use drugs like alpha-methyldopa, labetalol and nifedipine. In pregnancy-induced hypertension, again you can use labetalol, hydralazine and nifedipine. Yes, pretty simple. If you remember labetalol, you can understand that labetalol can be used everywhere in the pregnancy. Yes. Now, coming to the third chapter, that is heart failure. We have two kinds of heart failure. One is HFrEF, the other one is HFpEF. HFrEF means reduced ejection fraction, PEF means preserved ejection fraction. Now, according to the ACC/AHA guidelines of heart failure, we have a pretty good treatment for HFrEF. So, we are going to discuss the treatment of HFrEF. Okay. So, everything is here is about HFrEF. HFrEF means ejection fraction is reduced. So, let us suppose if there is a damage to heart, its ejection fraction is reduced, what will happen? The heart will feel bad obviously, and it is going to tell the brain to do something. Yes, what will the brain do? Brain will listen to our heart and it will activate the sympathetic nervous system. Sympathetic nervous system, this much you already know. We talked about it in the sympathetic nervous system. It is fight or flight response. What is released? Norepinephrine. So, norepinephrine is going to be released and it will act on all the receptors like alpha and beta. Now, if it is acting on the alpha receptor on the blood vessel, it will cause vasoconstriction. It will cause vasoconstriction. Now, if this norepinephrine is acting on the beta 1 receptor of the heart, beta 1 receptor of the heart, it will increase the heart rate, it will increase the contraction. See, our contraction is decreased. In EF is decreased means contraction is decreased. That is why our body is trying to compensate it by increasing the contraction. Good thing, no? Good thing. Yes. So, this is one good thing. Okay. But what has happened? There is vasoconstriction and increased heart rate as well. This will further worsen the heart failure. So, let us suppose a person is having EF of 40 and our person heart is trying to make this EF into 60. So, in this process, it is activating the sympathetic nervous system. But this sympathetic nervous system is causing further damage instead of repairing it, and from 40 it will fall to 38, from 38 it will fall to 35. So, this is how HF-REF is going to happen. It is a cyclical process that our body is doing. So, we have to break this cycle. Did you understand? Now, beta 1 receptor is also present in the kidney. If this is activated, it will activate renin-angiotensin-aldosterone system. Renin-angiotensin-aldosterone system. Now, when all of this is happening, you don't want all of this to happen. So, you have to give these drugs to stop the compensatory mechanisms that is happening by the body. First, for vasodilators, you will give for vasoconstriction, you will give vasodilators. Example is nitrates. But you don't use it for prophylaxis, you use it in acute episodes or acute attacks. So, if a person has symptoms, then you use nitrates. But if the person is not having symptoms, if you want to stop the progression of HF-REF, you cannot cure HF-REF, you can only stop the progression. How can you stop it? See, this is happening because of beta receptor. So, the first drug you are going to give is a beta blocker. So, the first drug you are going to give is a beta blocker. Then, vasoconstriction can also be blocked. Vasoconstriction can also be blocked, and renin-angiotensin-aldosterone system can also be blocked by ACE inhibitors. Now, we have a new drug that is better than ACE inhibitors, that is ARNI. ARNI means angiotensin receptor blocker plus neprilysin inhibitor. Okay. To stop this aldosterone, we will give aldosterone antagonist, that is spironolactone. Now, we have seen one drug in diabetes mellitus that is also useful in heart failure. So many questions have been asked on this drug so many times, that is SGLT2 inhibitors. Why? It has got good mortality benefit in HF-REF. SGLT2 inhibitors are gliflozins, dapagliflozin, empagliflozin, all these gliflozins. So, all of these are the first line drugs that you use in the prophylaxis. Yes, for chronic HF-REF. So, what are the drugs? Beta blockers, ACE inhibitors or ARNIs, aldosterone antagonist or SGLT2 inhibitor. So, what do you say? See, when EF is reduced, our sympathetic nervous system is overacting. Yes, it is overacting and damaging the body. So, we tell our sympathetic nervous system to stop. Bus, काम करना बंद कर दो. Yes, bus, stop. So, that is the mnemonic here. Beta blocker, ARNI, aldosterone antagonist, SGLT2 inhibitors. So, these are the first line drugs. So, these have very good mortality benefit. That is why these are first line drugs. So, they will ask you which drugs will decrease the mortality or which drugs have very good mortality benefits. These four drugs will reduce the mortality. That is why these are the first line drugs. Now, first we will see the first line drugs. Beta blockers are, we use 3 beta blockers, MBC, metoprolol, bisoprolol or carvedilol. We can start with any of them. Usually we start with carvedilol. Now, ACE inhibitors or ARB, which is better? ACE inhibitor is better. But ARNI is even better than ACE inhibitor in heart failure. Okay, ARNI is even better. But best is ARNI. What is ARNI? It is valsartan plus sacubitril. Why we are giving ARB plus neprilysin inhibitor? Because neprilysin inhibitor will also cause angioedema. If you give it along with ACE inhibitor, it will also cause angioedema. So, there is severe angioedema. So that is why these are contraindicated together. They cannot be given together. Before we made a drug called omapatrilat. It is ACE inhibitor plus neprilysin inhibitor. It has caused severe angioedema in patients, so this has been banned. Now, aldosterone antagonist, I already told you, spironolactone, finerenone. Spironolactone will have gynecomastia and menstrual abnormalities. That is why we will prefer finerenone. SGLT2 inhibitors, canagliflozin, empagliflozin, dapagliflozin. So, what are the drugs that are decreasing the mortality? Drugs decreasing the mortality. I already told you that mnemonic, bus. All these drugs will decrease the mortality. So, these have very good mortality benefit. Okay. Now, there are other drugs which will decrease the mortality in some patients, but not up to this level, but in some patients it does. What are those drugs? These are ivabradine. Okay. Versigouat. If you know Riociguat, Versigouat is also somewhat similar to that. Yes. Now, last one is, so if you remember Riociguat, Versigouat is also similar to Riociguat. It is a guanylyl cyclase stimulator. Okay. Now, last is hydralazine plus nitrate, isosorbide dinitrate. So these three drugs will also decrease mortality to some extent. Usually what they will ask in the exam is which drug does not decrease mortality or does not have mortality benefit, that is digoxin. Digoxin has no mortality benefit. Please remember, more than enough. If you cannot remember all this, at least remember digoxin has no mortality benefit. So this is about chronic HFrEF. Now, from the chronic case, if suddenly something worsens, it will cause acute heart failure. That is what is known as acute decompensated heart failure. Now, there are 4 classes in this. For you, the last 2 are important. One is pulmonary edema. Pulmonary edema, you studied so many times in the medicine. Yes, bat wing appearance that you see, frothy sputum, pink sputum, all of these are happening. Now, what is the treatment in pulmonary edema? You will give IV furosemide. This is what I want you to remember. You give IV diuretics, that is IV furosemide. Now, coming to cardiogenic shock. Now, what is cardiogenic shock? See, when there is acute decompensated heart failure, it is also known as acute congestive heart failure. Yes, acute congestive heart failure. What is the drug of choice? Drug of choice is dobutamine. Dobutamine is a beta-1 agonist. I already told you this in the SNS chapter, if you remember. If dobutamine cannot be used, what do I mean by dobutamine cannot be used? If a person is on beta blocker, a person is having chronic heart failure, then he is having acute heart failure. That means he is already taking beta blocker. No. And if you give dobutamine, will it work? It will not work. Why? Because this beta blocker is blocking this beta-1 receptor. Did you understand? We are giving is selective beta blockers mostly, so it is blocking this beta-1 receptor. So what can we do? We can use a drug called milrinone. It is a enodilator. That means it will cause inotropy as well as vasodilation. Why? Simple way to say that beta-1 receptor is a GS receptor. We've already studied beta-1 is a GS receptor. So GS receptor, how does it work? It will work by increasing the cyclic AMP. This cyclic AMP is what is causing vasodilation. Why? Because it is smooth muscle relaxation. I told you GS will stimulate everything except smooth muscle. So it is causing vasodilation and it will also increase the cardiac contraction. So basically, this is inotropy, this is dilation. Now, if you give milrinone is a PDE3 blocker. What will PDE3 do? Cyclic AMP is metabolized by PDE3. Now, if you block this PDE3 by giving milrinone, this cyclic AMP will increase. When the cyclic AMP increases, cardiac contraction will increase, vasodilation will increase. So what will happen? Inodilation. That is why we call it inodilator. Did you understand this much? Acute congestive heart failure, dobutamine. If this does not work, we will give milrinone. Now we have a new drug called levosimendan, but we are not using it. We are now using milrinone. Now, if a person has acute congestive heart failure along with decreased BP or hypotension, that is what is known as cardiogenic shock. And in cardiogenic shock, you can use norepinephrine. It is norepinephrine. I told you norepinephrine is a potent vasoconstrictor, so it is drug of choice in almost all the shocks except for anaphylactic. Yes, anaphylactic shock we use epinephrine. This is what we studied in the beginning of ANS. That is why I told you ANS comes everywhere. It is the most important chapter. So, we are done with this heart failure. Yes. Now, coming to the fourth chapter in this, it is about the anti-anginal drugs. Now, all of you know it is angina. Angina is because the chest pain, there is decreased oxygen supply to the myocardial muscles. Yes, you know. So, there is increased demand and decrease supply. So, what you should do in angina, you either have to increase the supply or decrease the demand. Demand is because of heart rate. Yes. So, you can decrease the heart rate. You can decrease the heart rate by giving beta blocker. Yes. Or you can increase the supply of the blood by giving nitrates. So, these two drugs we use it in all coronary artery diseases. Now, coronary artery diseases we have two kinds. One is chronic stable angina and the other one is ACS. ACS means acute coronary syndrome, as you know. In ACS, the troponin I is elevated. When troponin I is elevated, it tells you that it is infraction. It is not ischemia anymore, it is infraction. So, basically what I am telling you, please try to remember this, coronary artery disease, I am saying we have angina, that is chronic stable angina as well as ACS. So, first starting with the chronic stable angina, I told you have to use nitrates, beta blockers, and since it is a coronary artery disease, it is happening in the arteries, there is plaque formed with platelet. So, you have to give an antiplatelet drug, that is aspirin. Now, there are pleiotropic effects of statins, that is the reason why statin should also be used in coronary artery disease. So, these are the four drugs that you use almost everywhere. What do I mean by this? See, this is the treatment of chronic stable angina. Now, if a person is having acute coronary syndrome, in this there are again divided into two, NSTEMI and STEMI. Now, in the ECG, if there is ST elevation, we call it STEMI. If there is ST depression, we call it NSTEMI. So, coming to NSTEMI, what are the drugs that we are using here? If you see, nitrates, beta blockers, statin and aspirin, again, I told you, these are going to be same everywhere. But in ACS, you have to give dual antiplatelet therapy. So, you have to add one more antiplatelet, that is clopidogrel. Now, what you have to do in NSTEMI, you have to give an anticoagulant as well. Anticoagulant, it could be heparin, or the patient might need PCI. So, it is plus or minus, might need PCI. You will do after 24 hours. Okay, it depends on the condition. Now, coming to the STEMI. STEMI means rupture of the plaque and then there is fibrin clot formation. So, again when there is STEMI, you have to give all of these drugs, nitrates, beta blockers, statin, aspirin, clopidogrel. But since there is clot that is blocking the entire artery that is made up of fibrin, you can either do PCI. It is to be done within 90 minutes. If PCI is not available, then you go for thrombolysis. How do you do it? With the help of streptokinase. That's all. Did you understand? Angina is nothing but increased demand, decreased supply. Now, how can you do this? How can you reverse this? You give a beta blocker, you give a nitrate, and you also give an antiplatelet drug, you also give a statin. This is going to be same in almost everywhere. In STEMI, you are going to add a dual antiplatelet along with anticoagulant. STEMI, again dual antiplatelet along with thrombolysis or PCI. PCI is preferred. If it is not available, you are going to do thrombolysis. Now, there are some other anti-anginal drugs that we are going to see. They have been asked in the exams about their mechanism of actions. It is going to be easy because everything is in their name. Everything. Let me tell you how. See here, the first drug is ivabradine. Now, it acts on IF channel. This is funny current channel. Now, you see here VA. The side effects are visual abnormalities like luminous phenomena, you can see here, and phosphenes. Now, if you see here BRAD, it is also causing bradycardia. It is also causing bradycardia. You see here, it is also causing bradycardia because it is blocking the IF current on the SC node. That's all. It also blocks the IF channels on the eye. That is why it causes these side effects of visual phenomena. Yes, luminous phenomena and phosphenes. Now, coming to the ranolazine. Now, how is this working? Again, it is given here. It is blocking the late inward sodium channels. La means late, In means inward, again N means sodium channels, Na channels. So, late inward sodium channel blocker. Now, next is nicorandil. Nicorandil, CO, instead of C, you remember it as K. KO is potassium channel opener. It is potassium channel opener. Now, trimetazidine. How can you remember this? Trimetazidine. Yes, see here carefully. IN means inhibiting. It inhibits the metabolism of triglyceride by blocking PFOX. See, heart usually uses fatty acids for their metabolism when the entire organs use glucose, but our heart is using fatty acid. So what will this trimetazidine do? It will convert the fatty acids dependence to glucose. So heart will start using glucose as its fuel instead of fatty acids. Why? Because fatty acid oxidation requires a lot of ATP. It is energy consuming process. So when we turn it into glucose, our ATP is saved and we are helping the heart. That is why trimetazidine is helpful in the chronic stable angina as well, because it is decreasing the demand. Now, next is Prince metal angina. This is also known as variant angina. This is also known as vasospastic angina. This is happening because of vasospasm. Yes, so because of vasospasm it is happening. How can you treat it? During the acute attack, you have to give nitrates. But for prophylaxis, for long-term prophylaxis, the drug of choice is calcium channel blocker. That's all about the anginal drugs that you see even in medicine as well. Okay. Now coming to anti-arrhythmic drugs. Now, listen carefully. I'll tell you one or two mnemonics. With the help of this, you'll be able to understand the entire arrhythmics chapter, even from the medicine as well. You'll be able to solve all the questions from pharma and medicine. Please listen carefully for the next 15-20 minutes. Yes. Now, see here. How does an action potential work? How does an action potential take place? If you see here, action potential, how does it work? First, there is depolarization. Then there is repolarization. Yes. How does depolarization happen? With the help of sodium going inwards. This is what you studied in physiology. How does repolarization happen? With potassium coming outwards. This is what is happening. Simple. If sodium, that means positive charge, is going inside, it is causing depolarization. Now depolarization is relaxation. So potassium, that is a positive charge from inside the cell, is going outwards. That's all. So that is depolarization, repolarization. Now, if you take an example of a myocardial cell, let us suppose this is a myocardial cell in the ventricle. How does the action potential takes place? Let us see. Obviously, I told you this is depolarization, sodium will go inside. Okay, then what should happen? There should be repolarization. So potassium is coming outside. Perfect, amazing. But in the heart, once the potassium starts coming outside, unfortunately the calcium is going inside. You see here, calcium is going inside, that is a positive charge, but potassium is coming outwards, that is a positive charge. So positive, it cancels out. What will happen? It will remain as a plateau. It is not changing. Now, after a point of time, these calcium channels will close. Once these calcium channels will close, obviously the same thing is going to happen. The potassium comes out as usual. That is the reason why in the myocardial cells, during repolarization, there is a plateau. This is what is happening. When does depolarization happen? During contraction. When does repolarization happen? During relaxation. This is a ventricular cell. So what is this? When is the systole or contraction starting? Q. When is it? ending, the relaxation is ending at T. So this is what is known as QT segment. Will you accept? This is what is known as QT segment on ECG. This is how you can correlate. This is how you can correlate. Now what happens in arrhythmia? What happens in arrhythmia? In arrhythmia, the heart rate is increased. If the heart rate is increased, what will happen to these QTs? They will become smaller like this. Yes, they will become smaller like this. Now, what should be the treatment of arrhythmia? What should be the treatment of arrhythmia? Obviously, you have to increase this QT, no, you have to increase this action potential. How can you do it? You can either block sodium channel. If you're blocking sodium channel, what will happen? It will become like this. Or you can block potassium. If you block potassium, what will happen? See, it will stretch out like this. Okay. You can either block sodium or you can either block potassium. If you block sodium, this will happen. If you block potassium, this will happen. Did you understand? Now, so is it safe to say some block sodium channels, some block potassium channels? Now, which one would you like to block? If it is me, I would like to block potassium channels because potassium is working for a longer period of time. So I can say some block sodium channels, some block potassium channels. But I would prefer potassium channels. That is why I am going with the mnemonic. Some block potassium channels in arrhythmia. That's all. Now, drugs are magnesium sulfate. Now, why am I saying like this? We'll see. Some block potassium channels in arrhythmia, drugs are magnesium sulfate. Remember this. Now, some. S for sodium. First is sodium channel blocker. Next is beta blocker. Next is potassium channel blocker. Next is calcium channel blocker. These four are the first four classes of drugs. Did you understand? This is what is von Willems classification. Von Willems classification in the anti-arrhythmics. What are they? Von Willems classification. It is class 1, class 2, class 3, class 4. I already told you. Some block potassium channels. So first is sodium channel blockers. The second one is beta blockers. Third one, what is it? It is class 3 potassium channel blockers. Class 4 is calcium channel blockers. That's all, done with the mnemonic. Now, what are the other drugs? In arrhythmia? A for adenosine, D for digoxin, another A for atropine, magnesium sulfate for magnesium sulfate. That's all. These are the other drugs. So all the drugs in arrhythmia are done. That's all. Class 1, class 2, class 3, class 4 done, and these are the other drugs. You are done with all the anti-arrhythmic drugs. Now you just have to remember the uses. Now, class 1, if you see the class 1 is unfortunately again divided into 3. If you have attended my class, I usually tell you a story about how a girl, buys fleas. So I remember it with the help of a mnemonic. For people who have attended my class, you know this. Queen likes fleas. This is what I tell in the class. Queen likes fleas. So Q is for quinidine, likes is for lignocaine, fleas is for flecainide. These are 1A, 1B, 1C. All of them will block what? Sodium channels. Now, how did the queen buy the fleas? She bought the fleas in a box. So I remember it like this box. What is this box? See, B means it also blocks potassium channel. O means it opens potassium channel. X means no effect on potassium channel. Why am I saying all of this? Why do I have to remember all of this? See, if it blocks potassium channel, what will happen? There will be a QT prolongation. Because potassium is almost everywhere in the repolarization. It will cause QT prolongation. Yes. So 1A drugs will itself cause QT prolongation. If you cannot remember box, just remember Q for Q. Quinidine will cause QT prolongation. Yes, quinidine will cause QT prolongation. I told you potassium channel blockers will cause QT prolongation. So this will also cause QT prolongation. That's all. These are the most important MCQs that are being asked. Third class drugs. What are they? Potassium channel blockers. Now 1A drug, what are they? Quinidine and procanamide, they will also cause QT prolongation. This is very important. Why? QT prolongation can cause a torsade D point test. Yes, so that's all about the first class. Second class are all beta blockers. Third class is potassium channel blockers, that is amiodarone. Now amiodarone is a potassium channel blocker, true. It is also blocking the sodium channels, true. It is also a calcium channel blocker, true. It has some beta blocking activity also, yes, some. Now, so it is a wide spectrum drug. So amiodarone can be used almost everywhere. What is important about this? Its side effects. Its side effects will have thyroid abnormalities, and most importantly, it will cause ILD, or pulmonary fibrosis. Now this is about the class 3. You also have ibutylide and other drugs, but important is amiodarone. Now what is important is sotalol. Sotalol, it is a beta blocker, but it is a class 3. Beta blockers are class 2, but sotalol is class 3. Please remember this. Class 4 is calcium channel block. DHP or non-DHP? Tell me, which is decreasing the heart rate? Obviously, DHP or non-DHP? It is non-DHP. So, verapamil and diltiazem. That's all these classes of drugs. Now, if you understood this much, now I'll tell you how to solve any questions in the arrhythmias. Yes, see here carefully. Let us suppose a person is having arrhythmia and his BP is stable. That means BP is normal. If the BP is normal, we call him hemodynamically stable patient. True. So you see here this arrhythmias. In a hemodynamically stable patient, let us suppose the examiner will ask you two things. It could be either an atrial tachycardia, that means a supraventricular tachycardia, or the examiner might ask you about the ventricular tachycardia. So supraventricular or ventricular. Now in the supraventricular tachycardia, I am dividing it into two classes which examiner usually asks. That is PSVT. PSVT means a paroxysmal supraventricular tachycardia. Now PSVT again it has two types, AVRT and AVNR. Okay, this is one class. The other one is atrial fibrillation or atrial flutter. So SVT I have divided into two groups. Remember this, PSVT, atrial fibrillation or atrial flutter. Now how is PSVT happening? It is because of AV node re-entrant tachycardia. So in layman terms, if you take this is the AV node, this is the SA node. Yes, in the AV node, the impulses will keep on rotating. Yes, if it keeps on rotating, the impulse will go again and again. Yes, so this will cause increased heart rate. That is what is known as arrhythmia, since it is originating from the above the ventricles. This is what is known as paroxysmal supraventricular tachycardia. Now, the pathology is at AV node. If you block this AV node, you will terminate the arrhythmia. Yes or no? So what is the treatment here? AV node blockers. It is AV node block. Yes. Now, which AV node blockers can you use? I am telling you the best AV node block, A, B and C. A for adenosine, B for beta blocker, C for calcium channel blocker. And this is what we have taught. Yes, beta blocker will also block AV node. Calcium channel blockers like verapamil and diltiazem will also block AV node. Adenosine will also block AV node. So that's all. So if you see carefully, adenosine is only available in IV. It works only for 6 minutes. Yes, that is why you give it in a rapid flush. Now listen to me carefully. If you give any of these AV node blockers, this will terminate the arrhythmia. Termination of arrhythmia is known as rhythm control. That's why these are used in rhythm control. So that is why you see in your questions PSVT. If a person is hemodynamically stable, what is the first drug that you would use? It is IV adenosine 6 mg. Did you understand? Now, if a person is having acute PSVT, we will use adenosine. That is good because it is IV. Let us suppose a person is had PSVT and now you want to prevent the further attacks of PSVT. For long-term management or prophylaxis, which one would you use? You cannot keep on giving injections. Yes. Now, so you would use beta blocker. This is 6 mg, not 6 minutes. It will work less than 6 minutes. It is the shortest acting drug. The dose is 6 mg. Okay. Now, for prophylaxis, you would use beta blocker. Did you understand? Acute attack, adenosine. Prophylaxis, beta blocker. Now, let us suppose, they are telling you that a person is having PSVT and he has a history of bronchial asthma. Now, in bronchial asthma, you cannot use adenosine and beta blocker as well. So, in bronchial asthma patient, you will use calcium channel blocker. I hope you got it. That's all about PSVT. PSVT, you covered all the questions from AIIMS, NEET PG and also the FMGE. This is what they are going to ask. Vagal maneuvers and all can be done before the pharmacological stuff, but after vagal maneuvers, ice packing, this doesn't work most of the times. When you come to pharmacology, you have to use the AV node blockers. AV node blockers are adenosine, beta blocker, calcium channel blocker. Adenosine for the acute attack, A. For prophylaxis, beta blocker. If a person has bronchial asthma, you cannot use both of them, you will use calcium channel blocker. Yes, this is PSVT. Please remember this. Now, coming to the atrial fibrillation and atrial flutter. Why is AFib or A-flutter happening? See, this thing is because of AV nodal reentrant tachycardia. But what about AFib and A-flutter? There is a ectopic focus. Depends on AFib or A-flutter, there is a ectopic focus. What will this ectopic focus do? It will give you lot of impulses. So many impulses, See, PSVT, it is somewhere around 200 or whatever it is. But this one will give you so many impulses. When these impulses has to go through AV node again. These impulses have to go through AV node again. Let us suppose if these impulses go through AV node, the rate of ventricles will increase. If their rate of ventricles are increasing too much, ventricle will start pumping like this. If it is pumping like this, the blood will not go into aorta. If the blood is not going into aorta, yes, the person will become hemodynamically unstable, person might go into syncope, person might even die. So that is why you don't want the rate of ventricles to increase. So you don't want these impulses to pass through AV node. So here also you are blocking the AV node. If you block the AV node, are you terminating the arrhythmia? No, you are not terminating the arrhythmia. You are only blocking the rate of ventricles. That is why this is known as rate control. Please understand carefully. Here AV node blockers are used for rate control, not rhythm control. Rate control AV node blockers in AFib and atrial flutter. AV node blockers are used for rhythm control in PSVT. So if you are giving AV node blockers, you can control the rate. In AFib and A-flutter, adenosine unfortunately doesn't work properly because it is a short-acting drug. So here in AFib and atrial flutter, we will use the drugs called BCD. B is beta blocker. C is calcium channel blocker. D is digoxin. Did you understand? Beta blocker, calcium channel blocker and digoxin. Now, if you see here carefully, you might have seen in the questions, atrial fibrillation question, they will ask you which drug can be used to control the rate. That is beta blocker. Always beta blocker. Now, if a person has bronchial asthma, you cannot use beta blocker, so you will use calcium channel blocker. Now, let us suppose a person has HFrEF, means heart failure. You cannot even use calcium channel blocker. Why? If you use calcium channel blocker, it will reduce the contraction. So it cannot be used in HFrEF. Then you will use the last drug, that is digoxin. Did you understand? That is why in medicine you would have studied the only indication for digoxin is HFrEF plus AFib. This is the reason you have studied. So digoxin is used in HFrEF plus AFib. In bronchial asthma, calcium channel blocker. Beta blocker is the drug of choice. So this is what I want you to understand. To control the rate, BCD drugs in AFib and atrial flutter. But what about rhythm control? To terminate the arrhythmia, you have to stop the action potentials in the foci. You will do it with the help of amiodarone. Now, if you go to ventricular tachycardia, it could be VTAC, it could be VFib, anything, the rhythm control is always done by amiodarone. But only exception is in digoxin induced ventricular tachycardia, you will use lignocaine. You will use what? Lignocaine. That's all. That's all you have to remember. If you know this much, you will solve all the questions. So patient is hemodynamically stable. If he is having PSVT, you will use ABC. If he has AFib or atrial flutter, BCD. If they are asking rhythm control, amiodarone. If they are asking rhythm control in BTAC, it is amiodarone. VFib, amiodarone. But if they are asking digoxin-induced arrhythmia, it is lignocaine. If it is hemodynamically unstable patient, then you will go for DC cardioversion, that is what shock. It does not matter what kind of arrhythmia he has. If he is having hemodynamically unstable, then you should always go for the DC cardioversion. That's all about this entire arrhythmia. Okay, if you understood this, you will answer all the questions about arrhythmias. So we will see here atrial tachycardia, PSVT, which control? Rhythm control. What are the drugs? AV node blockers. What are they? ABC. AFib, rate control. AV node blockers. What are they? BCD. Rhythm control. Amiodarone. Ventricular tachycardia. Again, amiodarone. Okay. Now, if you see here, purple man syndrome. Yes, purple man syndrome or blue man syndrome, I would call it. Purple or blue. Yes, I would prefer blue. Blue man syndrome is caused by amiodarone. Yes, purple toe syndrome is caused by warfarin. Purple glove syndrome is caused by phenytoin. Okay, these are the important things about the colors. Now, coming to WPW syndrome, it is an accessory pathway. So, the best treatment of choice is to ablate this accessory pathway. So, treatment of choice is radiofrequency ablation. This much you already know. Now, coming to the acute episode, you can use procainamide or flecainide. Prophylaxis only flecainide. Yes. Now, towards our AD pointers, you will use magnesium sulfate. We have finished almost all the drugs. Atropine we have studied in the first itself. I told you 5 drugs of choices. Atropine is drug of choice in bradycardia. Atropine is drug of choice in AV nodal block, OP poisoning, carbamate poisoning, early mushroom poisoning. That much you already know about atropine. Now, if it is a digoxin-induced arrhythmia, you will use lignocaine. With digoxin, what are the things that you have to remember? Digoxin, what is the antidote? It is digibind. It is what? Digibind. What is the mechanism of action of digoxin? It is an inotropic drug. It will also cause side effects like gynecomastia. And xanthopsia. Yellow greenish vision. It is xanthopsia. Now, what is important? If you see N, it produces a specific arrhythmia, that is what is known as non-paroxysmal atrial tachycardia with AV node block. This is a specific arrhythmia that is seen by digoxin. This is what I want you to remember about the digoxin. Now, coming to the last part, pretty simple, all of you know this. I am just going to rush through it. It is anti-dyslipidemics. If you want to decrease LDL, we have all these drugs. If you want to decrease triglycerides, we have fibrates. If you want to decrease lipoprotein here, we have niacin. Now, first start with the LDL. What is the drug of choice to decrease the LDL? It is statin. How do they act? By blocking the HMGA-CoA reductase. This is the rate limiting step in the cholesterol. Yes. So, HMGA-CoA reductase, but it is contraindicated in children and pregnancy. So, in children and pregnancy, what are the drugs that you can use? These are bile acid racines. These are drug of choice in children and pregnancy. You have to remember this. Now, these questions have been asked in NEET. Not all of them. The most important question that they have asked is NPC1L1, Niemann-Pick-like receptor, is blocked by ezetimibe. PCSK9 is blocked by evolocumab and alirocumab. Yes. PCSK9 synthesis is blocked by inclisiran. This is what I want you to remember. That's all. Now, coming to fibrates, the side effects is myopathy and it can cause toxicity. With clarithromycin. I already told you. Clarithromycin. It can cause toxicity with clarithromycin. What is it? It is statin, not fibrate, it is statin. Statins will cause toxicity with clarithromycin and this will also cause myopathy. Statin myopathy is seen with clarithromycin. We have studied in enzyme inhibitors because statins are also metabolized by CYP3A4. Okay, good. Now, niacin, it decreases the lipoprotein A, and niacin will also induce flushing. Now, in this flushing, in the olden days we used to use aspirin. Now we have a specific drug that is known as lorapiprant. So that's all about the entire cardiovascular system. We'll do the questions. We'll understand about these arrhythmias, about how to use in PSVT and how to use in the atrial fibrillation. Then you will understand the entire topics. Yes. As I've told before, here are some of the questions to see how much you have really understood the concepts. So, the first question that we're going to see here is, a 28-year-old man has been diagnosed with bronchial asthma. Obviously, then he would be started on inhaled corticosteroids to decrease the inflammation. During the follow-up, he mentions that he has observed another patient on similar treatment developed a white patch on his tongue. Now, other patient has developed a white patch on the tongue. Why? See, inhaled corticosteroids, these will reduce the immunity in the oral cavity, so it can cause fungal infection. So it has caused oral candidiasis. Yes. Now, the patient is asking, how can you prevent this? Yes. Now, here are the options: pressurized meter dose inhaler and nebulizer, spacer, or dry powder inhaler. What will you do? Yes. Obviously, I've already told you, you have to use a device called a spacer. Now, coming to the 14th question, this is really important. Listen to me carefully. A 25-year-old woman on OCPs presents with a persistent cough for the past 4 weeks associated with low-grade fevers, night sweats, anorexia, and unintentional weight loss. She also reports occasional streaks of blood in her sputum. On examination, she appears thin and pale. Okay. On chest auscultation, there are coarse crepitations in the upper lung zone. She started on ATT. Why? Because night sweats, fever, all of these are presumptive TB case. Yes, so she has been started on ATT. Now, what is the ATT? It is HRZE. 2 months of HRZE followed by 4 months of HRE. So, after she started on ATT after sputum analysis and other investigations confirmed the diagnosis. Okay. A few months later, despite the regular use of her OCPs, she is found to be pregnant. Why? It is because of drug interactions. That much you already know. Now, in general pharma, I already told you that rifampicin. Rifampicin is an enzyme inducer. Rifampicin is an enzyme inducer. So, if it is an enzyme inducer, it will increase the CYP enzyme activity. Yes, and it will increase the metabolism of OCP. And when the metabolism of OCPs are increased, the effect will decrease. Did you understand? So it is causing OCP failure. That is what I told you. Rifampicin will cause OCP failure. Now it will be pretty simple. You don't even have to look at the options. Rifampicin induces hepatic microsomal enzymes causing OCP failure. Now, coming to the 15th question. A 15-year-old man with a history of chronic stable angina. He presents to the cardiology clinic for a routine follow-up. His past medical history includes hypertension and hyperlipidemia. He has no history of myocardial infarction. He is on medications like aspirin, oral isosorbide mononitrate, that means nitrates, metoprolol, and atorvastatin. The patient has recently developed erectile dysfunction. So, without informing his physician, he has obtained sildenafil. Now, what is the most potential adverse effect that can be closely monitored in this patient? What can be seen in all of this? Now, is it increased frequency of angina episodes? No, it will not increase the frequency of angina episodes. Is it development of persistent priapism? Is it increased risk of gastrointestinal upset? Significant and potentially dangerous drop in blood pressure. Now, if you remember, nitrates, what will it do? It will increase the cyclic GMP. Yes, this will cause vasodilation. Now, this is metabolized by phosphodiesterase. Sildenafil is a phosphodiesterase blocker. If you block the metabolism, this will increase. If this increases, vasodilation will also increase. If vasodilation increases, what will happen? It will cause to a It will cause potentially dangerous drop in blood pressure, that is hypotension. So this is the side effect that you have to monitor. Got it? Now, coming to the 16th question. A 45-year-old woman with a 5-year history of HFrEF. HFrEF presents to the cardiology outpatient department. Her current medications include valsartan sacubitril, that is an ARNI, carvedilol, beta blocker, spironolactone, aldosterone antagonist, vitamin D, and dapagliflozin. It is SGLT2 inhibitor. Now, she presents with complaints of burning micturition, vaginal discharge with pruritus, fever, myalgia, and lower abdominal discomfort. The urine examination was done and the culture and sensitivity reveals E. coli, that is more than 10 to the power of 5. Yes, 10 to the power of 5. Now, it is consistent with UTI. Which drug will cause UTI? This much you already know. Is it ARNI, beta blocker, SGLT2 inhibitor, or spironolactone? Yes, everybody should be able to answer this. This is a PYQ. It is SGLT2 inhibitor. I've already told you. If you block a sodium glucose transporter, what will happen? Sodium and the glucose, both of them are lost in urine. So, because of presence of glucose in urine, it can cause UTI. Now, in the arrhythmia chapters, if you remember the slide I gave you about the arrhythmias, I told you I'll give you one question on which you'll be able to understand the arrhythmia. Now, let us see. That is what is here. A 58-year-old woman presents to outpatient clinic with palpitations, fatigue, and shortness of breath on exertion. Okay. She also repeats dizziness and occasional mild chest discomfort. Okay. She has history of asthma with recurrent episodes of wheezing, and she is currently on inhaled corticosteroid therapy and bronchodilator therapy. She was diagnosed with HFrEF, heart failure with reduced ejection fraction, HFrEF, asthma. Okay. HFrEF, she was diagnosed 3 years ago and is on medical management. She is currently using ivabradine instead of beta blocker because beta blockers will worsen her asthma, obviously. Now, on examination, pulse is more than 100, BP is 130 by 80, ECG is taken and is shown below. Now, if you look at the ECG, these are all RR intervals. You see, are they regular? Are they regular? No, they are irregular. Are they regularly regular or irregularly irregular? Regularly irregular or irregularly irregular? You see here, there is no correlation between any RR interval, so it is irregularly irregular. That's what is there. So, irregularly irregular RR intervals is known as atrial fibrillation. So, the patient is having atrial fibrillation. Which of the following drug is the most appropriate first line choice for rate control? Rate control, not rhythm control, rate control. See here, beta blocker. Rate control, what are the drugs you will give in atrial fibrillation? I told you it is B, C and D. This patient is hemodynamically stable. Why? Because BP is 130. If BP is fallen, that is what is hemodynamically unstable. No. For hemodynamically stable patient, B, C and D. Now, this patient has, listen carefully, asthma. So, can you give beta blocker? No. So, beta blocker cannot be given because the patient has asthma. Amiodarone. This is for rhythm control. This is for rhythm control. You cannot give it for rate control. Now, coming to verapamil, it is a calcium channel blocker. But I told you, calcium channel blocker cannot be used in HFrEF because it will decrease the contraction. So, calcium channel blocker cannot be used. Verapamil is not the answer. What is left out? D for digoxin. That is why the answer is digoxin. Did you understand? So, this is how you have to rule out the questions. Let us suppose if the same question is given and the patient do not have any HFrEF or bronchial asthma. What is the answer? The answer is beta blocker. Let us suppose same patient is given and they told patient only has bronchial asthma, no HFrEF. What will be the answer? Answer will be calcium channel blocker. Let us suppose the same patient, they asked you rhythm control. What will be the answer? Answer is amiodarone. Yes? Now, we will start with the next chapter. Okay. Now we are going to start with hematology. The first chapter in hematology is the drugs acting on the blood flow. Now, as you know, if there is any injury to the blood vessel, now see here, when there is an injury to the blood vessel, what will happen? The platelets will come and try to form a clot or a thrombus. Let us see how is this happening. So, whenever there is an injury, first the platelets will come and attach to that site. That is what is known as platelet adhesion. Platelet adhesion. Now, first some amount of platelets will come, but we need a large number of platelets for the clot to form. That is why these platelets will cause secretion. They will secrete a lot of factors which will attract a huge number of platelets. Now, all of these platelets has to aggregate in between themselves. That is what is known as platelet aggregation. This is what you can see. The platelets are joining together. Now, let us suppose this is the next step that is happening. First, there is adhesion, then there was secretion, and then there is platelet aggregation. Once the platelets are aggregated, you can see here between the platelets we have something known as fibrinogen. Now, if you want to form a stable clot, this fibrinogen has to be converted into fibrin. This is what is known as coagulation pathway. First there was platelet aggregation, then there was coagulation. Once this clot is formed, this clot will come and attach here. You can see here. So this is how clot or a thrombus is formed. Now, how many types of thrombi do you know based on the location? You will have something known as arterial thrombi. Arterial thrombi means the thrombus is present in the artery. If it is present in the artery, the thrombus is mostly made up of platelets. So, will you use the drugs acting on the platelet or coagulation path? Obviously, the drugs acting on the platelets. That is why we tend to use antiplatelets for arterial thrombi. Examples are CAD, coronary artery disease, and stroke, because these happen in the arteries of brain and heart. Did you understand? So, in the brain it is stroke, in the heart it is coronary artery disease. That's all. Now, that is about the arterial thrombi. Now, we have something known as venous thrombi. In the veins, the fibrin content is more in comparison with the platelets. So, you would want to use anticoagulants. So, that is the reason why we will use anticoagulants in the venous thrombi. Now, the examples are deep vein thrombosis, because it is happening in the veins. Yes. Now, we have something called fibrinolytics. Fibrinolytics means this will break the fibrin after formation itself. After the fibrin is formed, these fibrinolytics will break this fibrin. Where do we want it? We use it in a condition called STEMI. You must have heard of a drug that is known as streptokinase. Yes, streptokinase. We use it in STEMI. These are fibrinolytics. So basically we have antiplatelets, anticoagulants, and fibrinolytics. In arterial thrombi, we are using antiplatelets. Venous thrombi, we are using anticoagulants. So first we will start with the antiplatelets. You can see here, these are the drugs. You must have studied it so many times. The first class of drugs is COX inhibitors. COX inhibitors will block thromboxane A2. The drug is aspirin. We've already studied all about aspirin and autocoids. Yes. Now, coming to ADP blockers. Yes. Now, ADP is a molecule which acts on P2Y12 receptor. So, if you are blocking this, if you are blocking P2Y12 receptor, what will not happen? This platelet aggregation and all will not happen. So, the drug names are clopidogrel, prasugrel, ticagrelor, and cangrelor. Clopidogrel, ticagrelor, cangrelor, all of these are P2Y12 receptor blockers. Now, coming to the thrombin. Yes, thrombin also acts on PAR receptor. You can block this PAR receptor. How can you block this PAR receptor? With Vorapaxar. You can see PAR. So, PAR receptor is Vorapaxar. GP2B3A blockers. These are epsiximab, eptifibatide, and tirofiban. Yes, at least remember epsiximab. Now, so COX inhibitors are aspirin. Next, P2Y12 receptor blockers are clopidogrel, ticagrelor, and cangrelor. PAR receptor blockers are Vorapaxar. GP2B3A blockers are epsiximab. That's all. These are all the antiplatelets that you need to remember. Now, coming to the anticoagulant, one that is really famous is warfarin. How is warfarin working? It blocks vitamin K epoxide reductase. Yes, it will block vitamin K epoxide reductase. Now, it can be used orally and onset of action is after 4 to 7 days. It works only after 4 to 7 days. But within the first 2 days, what will happen? There is something known as protein C. It is an anticoagulant factor. When this decreases, it can form thrombus in the lower extremities. Yes. So, it will give you this necrosis pattern. This is what is known as purple toe syndrome. So, it will cause something known as purple toe syndrome. Did you understand? It will cause purple toe syndrome. Now, it is contraindicated in pregnancy. It is contraindicated in pregnancy because it will cause fetal warfarin syndrome and hemorrhagic disease of newborn. So, warfarin is generally used for DVT prophylaxis in the olden days. Nowadays, we are preferring something known as NOAC or DOAC. We will talk about it. Now, why we are not preferring warfarin nowadays? Because it needs continuous monitoring. How do you monitor this warfarin? You monitor it with the help of PT-INR. You do PT and INR. Yes, we give most importance to INR. And what is the target range? When a person has thrombus, what is the target range of INR? INR has to be somewhere between 2 to 3. That is the target range. Now, if INR goes to more than 3, what will happen? There might be chances of bleeding. Yes, because you are stopping the coagulation pathway. So that is what, if there is warfarin dose and if the INR is going above the target dose, what will you do? See, according to Goodman and Gilman 13th editions, what are they saying? The textbook is saying that if INR is above the target range, you stop warfarin, and once the INR comes into the target range, you restart warfarin at lower doses. This is what they are saying. Now, they are also saying if INR is more than 10, that is when you start vitamin K. Now, doesn't matter what is the INR, if there is bleeding, then you have to give 4-factor complex. What are those 4 factors that you have to give? See, warfarin is blocking 2, 7, 9, 10 factors. So, you have to give these activated factors 2A, 7A, 9A, 10A. This is what is 4-factor complex. Along with this, you also give vitamin K. Why? Because vitamin K effect will take some time. Yes, when there is bleeding, you have to give already activated factors. Those are 4-factor complex. So, this is what the textbook is saying. When the INR is more than 10, you give vitamin K. But if there is bleeding, you have to give 4-factor complex as well. So, this is about warfarin. In anticoagulants, we were finished with warfarin. Now, what you need to remember, there are 10A blockers and 2A blockers. 2A means it is also known as thrombin. What are 10A blockers? It is given in the names. See, 10A, XA. When you are blocking it, you are banning it, or it is also known as antagonist. So, these are known as exaban. So, these are apixaban, rivaroxaban and edoxaban. So, these are 10A blockers. Easy to remember, all of these are oral drugs. Now, coming to 2A blockers, these are thrombin inhibitors. In this, you have 2 classes of drugs. One is direct, the other one is indirect. Direct means it directly blocks the 2A. It directly blocks the 2A factor. Yes, this is what I want you to understand. Now, direct, we have both oral and IV. Please remember the oral one, more important, it is dabigatran. D for D, it is direct, it is dabigatran. Yes, in indirect, you have argatroban and bivalirudin. Yes, argatroban and bivalirudin. These are the IV drugs. Now, if you see carefully, it is given in the name. Everything is given in the name. Thrombin means TR, thrombin antagonist. See, troban, thrombin antagonist. That's all. We are finished with the direct thrombin antagonist. Now, indirect ones. Indirect ones are the most famous ones. These are heparins. Yes, unfractionated heparin, low molecular weight heparin. Next is fondaparinux. That's all. Now, what I want you to remember is in both 10A and 2A, we have some oral drugs. All of these oral drugs together, these exabans and dabigatran, both of them together are known as DOAC or NOAC. Yes, DOAC means direct oral anticoagulants, NOAC means novel oral anticoagulants. Yes, so these are oral 10A inhibitors and oral direct 2A inhibitors. Why are we preferring this? Because it does not require any kind of monitoring. Yes, now coming to the drug of choices. Yes, what is the drug of choice for prevention or prophylaxis or of DVT? DVT is a venous thrombi, so you will use anticoagulants. Yes, obviously you have to give a oral drug. Will you give warfarin? See, warfarin requires a lot of monitoring. That is why you will give DOACs or NOACs. If you don't have DOACs or NOACs, then you will give warfarin. That's all. Before it used to be warfarin. Now we are preferring DOAC and NOAC. Now, drug of choice for acute treatment of DVT. Acute treatment of DVT. Here you have to give an injectable form, that is heparin. Low molecular weight heparin. You will get. That's all. This is about the DVT. Yes, you understood this much? Now, coming to the antidotes. What is the antidote for warfarin? It is vitamin K. It is vitamin K. Now, what is the antidote for dabigatran? It is idarucizumab. Yes, what is the antidote for XA blockers, 10A blockers? Yes, these are hexabans. What are the antidotes for this? What is the antidote for this? It is andexanate alpha. It is andexanate alpha. For heparin, it is protamine sulfate. It is protamine sulfate. For HIT, heparin induced thrombocytopenia. For HIT, what do you give? Argatroban. Now, there is a non-specific antidote for all the anticoagulants. What is this? It is siraparantarac. Siraparantarac. Yes, this is the non-specific antidote. It is not FDA approved as of now, so that is why I didn't give too much attention to it. But you have to remember all of this. Warfarin is vitamin K, heparin is protamine sulfate. 10A blockers are andexanate alpha. It is given in the name 10A. Yes, XA, hexaban. You will also give andexanate alpha for hexaban toxicity. Yes, that's all. Now, coming to hematopoietic agents. That means these are increasing the blood cells. Now, to increase the RBC, you can give erythropoietin. Yes, increasing RBC is what is known as erythropoiesis. You can give erythropoietin analogs. So, everything is given in the name. E-poietin alpha, erythropoietin. Darbepoietin, it is erythropoietin. Given in the name, I told you. So, next coming to granulopoiesis. That means you want to increase the WBCs. How can you increase the WBCs? You can give colony stimulating factors. Yes, one is granulocyte colony stimulating factor. The other one is granulocyte monocyte colony stimulating factor. This is GMCF. This is supposed to be GMCF. One is filgrastim. The other one is sargramostim. How do you remember? Grastim, granulocyte stimulating factor. Gramostim, granulocyte monocyte stimulating factor. Did you understand? GCF and GMCF. Now, coming to thrombopoiesis. How do you increase the platelets? By increasing the interleukin 11. At least remember one drug. This is oprelevicin. You can see here in the name itself we have 11. Yes, it is oprelevicin. These are oprelevicins. Yes, that's all. This is what I want you to remember. Yes, in this I want you to remember epoietin, darbepoietin, filgrastim, sargramostim and oprelevicin. These are most commonly asked drugs in the exams. So, this finishes our hematopoiesis chapter, the hematology chapter. Yes. Now we are going to start with the central nervous system. Central nervous system and the endocrine are covered in so many subjects. So, this is the main integral part of systemic pharma. So, we are going to go in a faster pace because these are covered almost in 2 to 3 other subjects as well. So, first we will start with the CNS. The first topic is about sedative-hypnotics. Sedation means it is causing anxiolysis and hypnosis means it is causing sleep. Now, which neurotransmitter does this? This is done by the help of GABA. How does this do it? GABA will act on GABA receptors. GABA A receptor, when it acts on GABA A receptor, What will happen? It will cause anxiolysis and it will induce sleep. Now, to do this, what are the drugs that we can use? If we directly stimulate GABA A receptor, will you not see the effects? Yes, you will. So, what are the drugs that are directly affecting the GABA A receptors? These are benzodiazepines and barbiturates. Benzodiazepines and barbiturates. Now, what about GABA? See, when GABA is released, it acts on GABA A receptors. Yes, I told you. Now, after this, the GABA is metabolized by something known as GABA transaminase. It is metabolized by GABA transaminase. Now, this can be blocked. This can be blocked with a drug called vigabatrin. This can be blocked by a drug called vigabatrin. It is given in the name. See, it is GABA transaminase inhibitor. GABA transaminase inhibitor is vigabatrin. Now, this remaining GABA can also be taken up by the GABA transporter, that is GAT1. This can also be blocked by drug called tiagabine. Tiagabine. It is transport of GABA inhibitor. Transport of GABA inhibitor. That is what is tiagabine. That's all. These are the drugs you want to or you have to remember. See, now we will go with the benzodiazepines and barbiturates. What are benzodiazepines? These are zepams. Yes, diazepam, lorazepam, all these zepams or zolams. Diazepam, flurazepam, alprazolam, lorazepam, yes, estazolam, all these drugs are benzodiazepines. Okay, now if you see, benzodiazepines have a flatter dose response curve in comparison with steep dose response curve. In barbiturates, what does this mean? See, steep dose response curve means it is a dangerous substance. That means if you increase the dose, it can become very toxic. So that is why you have to be very careful with dosing of barbiturates. Okay. Now, if you remember LETO, L-E-T-O, these drugs are liver safe. Lorazepam, estazolam, temazepam, oxazepam, all of these are liver safe. Now we have a drug called flunitrazepam. This is a date rape drug. Now, if there is a benzodiazepine toxicity, we have an antidote that can be used here. That is what is known as flumazenil. Now, in barbiturates, I already told you it has a steep DRC, so it is dangerous. What are the drugs here? The drugs are thiopentone. Thiopentone is actually the drug of choice in narcoanalysis. It is drug of choice in narcoanalysis. Now, coming back to phenobarbital. Phenobarbital is also drug of choice in Crigler-Nazar type 2 syndrome. Crigler-Nazar type 2 syndrome. Why is this syndrome happening? Because there are decreased enzymes. Barbiturates are enzyme inducers. So, if there is barbiturate toxicity, what would you do? It is given in the name barbiturate. A, it means acid. I told you. So, in acids, you have to give forced alkaline diuresis. Forced alkaline diuresis. So, we also have Z compounds in this class. These are zaleplon, zolpidem and S-zopiclone. These drugs can be used in insomnia. This is about the sedative-hypnotics. Now, we are going into the anti-epilepsy drugs. Now, anti-epilepsy drugs. Yes, in epilepsy, you do see seizures. Yes. So, what are the types of seizures that you know? There are focal seizures, generalized seizures. Generalized seizures means they are happening in almost all parts of the body. Focal seizures means in some parts of the body. Now, generalized seizures are always associated with loss of consciousness. Focal seizures might have loss of consciousness or might not have loss of consciousness. If there is no loss of consciousness, that is what is known as simple partial or simple focal seizures. Now, if there is loss of consciousness, that is what is known as complex focal seizures. Complex focal seizures. For simple focal seizures, these are most probably due to tumors. So you do a surgery and take it out. You give an anti-epileptic drug when the person is seizing, but they don't require a lifelong therapy. Now, coming back to the complex focal seizures, you have to give them anti-epileptic drugs. For complex focal seizures, previously the drug of choice was carbamazepine. But now in the clinics, we are using levetiracetam most commonly, that is Levipil. Did you understand? This is about the complex partial seizures. Now, coming to generalized. In generalized, again we have two types. One is motor, the other one is non-motor. If there is motor activity, these are motor seizures. What are they? GTCS, generalized tonic-clonic seizures, and JME, juvenile myoclonic epilepsy, atonic seizures, Lennox-Gastaut syndrome. In all of these, the drug of choice is valproate. So it is already done. GTCS, JME, atonic seizures, Lennox-Gastaut syndrome, the drug of choice is valproate. Now, coming back to the non-motor seizures are also known as absence seizures. Now, absence seizures are two types. These are typical, atypical. Typical seizures, you will have 3 Hz spike and wave pattern in the EEG. 3 Hz spike and wave pattern. How to remember? Typical 3. T for T. Yes. Now, you reverse this 3, it will become E. The drug of choice for this is ethosuximide. Drug of choice is ethosuximide. That's all. Now, atypical means less than 3 Hz. Less than 3 Hz, here the drug of choice is valproate. Here the drug of choice is valproate. That's all. These are the types of seizures. Now, we'll talk about some important side effects of the anti-epileptic drugs. The first one is going to be about valproate. Valproate is the most teratogenic anti-epileptic drug. Most teratogenic. Yes. Now, what are the side effects? If you remember valproate, you will know V for vomiting, A for alopecia, L for liver toxicity, P for pancreatitis. At least remember liver toxicity and pancreatitis. Yes, if there is liver toxicity, you can use an antidote, that is L-carnitine. It is L-carnitine. This is about valproate. Now, the important one is phenytoin. Phenytoin, the side effects of phenytoin are it can cause hirsutism, it can cause hyperplastic gums. The most important ones are megaloblastic anemia and hemorrhagic disease of newborn. It can also cause purple glove syndrome. It can also cause purple glove syndrome. P for P, please remember, purple glove syndrome. Now, next, carbamazepine. Carbamazepine was previously drug of choice in partial or focal seizures. Now, it is drug of choice in trigeminal neuralgia. Trigeminal neuralgia, it is drug of choice. Please remember this, trigeminal neuralgia, what is drug of choice? Carbamazepine. Now, coming to the side effects of carbamazepine. It will cause aplastic anemia. Yes. It will cause aplastic anemia. Now, and it will also cause agranulocytosis. Agranulocytosis. This is what is important. Agranulocytosis is also seen with clozapine. That is why it is contraindicated with clozapine. It is contraindicated with clozapine. That's all. Now, coming to lamotrigine, it can cause Stevens-Johnson syndrome. Topiramate is used in obesity with phentermine. Now, coming to the drug of choices. What is the drug of choice in eclampsia? The drug of choice is magnesium sulfate. Magnesium sulfate. What is the drug of choice in febrile seizures? These are rectal diazepam. It is rectal diazepam. Now, status epilepticus, what is the drug of choice? First, you have to terminate the seizures. You will terminate it by giving lorazepam. Once you terminate the seizures, you should prevent the seizures. So, lorazepam is followed by levetiracetam. Levetiracetam. Why are we preferring levetiracetam or lamotrigine? Because they will have less teratogenic effects compared to the valproate. Did you understand? Now, coming to pregnancy, I told you it is levetiracetam or lamotrigine. Why? Because it has less teratogenic effects. You can remember L for L, least teratogenic effects. Yes. Now, coming to infantile seizures or West syndrome. If we don't know the cause of West syndrome, it does not have tuberous sclerosis, it is ACTH. But if it is with tuberous sclerosis, this is going to be vigabatrin. We already talked about vigabatrin. It is GABA transaminase inhibitor. GABA transaminase inhibitor. Now, coming to the epilepsy in pregnancy. Let us suppose a female is pregnant and she is already taking anti-epileptic drugs and she became pregnant. Okay. Which anti-epileptic drug is she taking? Let us suppose she is taking valproate. What will you do? Valproate is very teratogenic. Will you change it? No, you should never change this. In fact, you should continue this and increase the dose of folate that you give during the pregnancy. Generally 400 micrograms are given during pregnancy, but you will give 4,000 micrograms. 4,000 micrograms. So you will still continue the drug and you will give 4,000 micrograms. Now, if a female is not on any AED and the epilepsy has first time started after pregnancy, so you have to start with a new anti-epileptic drug. During this time, you start with the drug that has least teratogenic effect. So what is it going to be? Lamotrigine or levetiracetam. Levetiracetam. I would prefer levetiracetam. Yes, that's all. This is about the anti-epileptic drugs. Now, coming to the antipsychotics. Antipsychotics means you use it during the schizophrenia. Why does schizophrenia happen? Schizophrenia is happening because there is increased dopamine. Increased dopamine will cause schizophrenia. So, what is the typical treatment of schizophrenia? You will decrease the dopamine. So, typical antipsychotics will decrease the dopamine by blocking the D2 receptors. These are D2 receptor blockers. Now, examples are haloperidol and thioridazone. What will be the side effects because of this? When you block D2 receptor, it will cause something known as extrapyramidal symptoms. It will cause extrapyramidal symptoms and hyperprolactinemia. Hyperprolactinemia. We will see what are these extrapyramidal symptoms. These are caused due to typical antipsychotics. Usually high potency, remember H for H, it is due to haloperidol. High potency is haloperidol. Yes, please remember this. Now, what are these EPS? We'll try to understand. The most common EPS is akathisia. Yes, akathisia is the most common. It is restlessness. Akathisia means restlessness. This is not acute dystonia, it is akathisia. Akathisia means restlessness, excessive movements. Yes. Now, how do you treat this? We don't know the cause. We treat it with the help of propranolol. Propranolol. Yes. Now, coming to the next one, it is acute dystonia. It is acute dystonia. Now, listen carefully. In substantia nigra, what usually happens is the dopamine and acetylcholine are in a balanced level. Dopamine and acetylcholine are almost in balance in substantia nigra. Let us suppose if you are giving typical antipsychotics, in substantia nigra, what will happen to the dopamine? Dopamine levels will decrease. Are the acetylcholine levels decreasing or increasing? No, they are remaining constant. So you see here, acetylcholine is constant, but dopamine has decreased. Yes. Now, acetylcholine levels are constant, but dopamine has decreased. So, if you see carefully, in comparison with dopamine, acetylcholine levels look high. In comparison with the dopamine, acetylcholine levels look higher. Did you understand this much? So, because of this acetylcholine levels, there will be muscle contraction. Since this is happening suddenly, there is sudden muscle contraction. Sudden muscle contraction will cause abnormal posturing, especially of the neck. It will cause what? Torticollis. It will cause torticollis. This is happening because ACH looks high. That is the reason why the treatment is benzhexol or scopolamine. Why? Because these are muscarinic blockers. Now, coming to Parkinsonism, drug-induced Parkinsonism. Now, if you are using antipsychotics for a long period of time, what will happen? This dopamine is decreased and acetylcholine looks high. This is how the Parkinson's disease looks like. Parkinson's means death of dopaminergic neurons in substantia nigra. No? So, what will happen in Parkinson? Tremor and bradykinesia. So, what will you do? The treatment is benzhexol. You can ask me, sir, dopamine is decreasing. Why don't we increase dopamine? See, dopamine we are decreasing because person has schizophrenia. If you increase this dopamine, again it will cause schizophrenia. No, that is why acetylcholine looks high, we will decrease it. So, that is why the treatment here again is benzhexol. Tardive dyskinesia. This happens because of receptor upregulation. So, even if some dopamine is released, it will still cause symptoms. Dyskinesia means increased movements, lip smacking and all of those movements. Now, what is the treatment? You don't let the dopamine release. Dopamine is released from VMAT2, vesicular monoamine transporters. Yes. So, you block those. How do you block those? By tetrabenazine, deutetrabenazine and valbenazine. Tetrabenazine, deutetrabenazine and valbenazine. Next, last but not least, it will also cause neuromalignant syndrome. Now, what is the drug of choice for this? It is dantrolene. It is dantrolene. This table is really important. That is why I took my time to explain it. This table is pretty important for the exam. Now, atypical. Why did we make atypical? Because in typical, there are lot of EPS and hyperprolactinemia symptoms. So, we made atypical antipsychotics. These will not block dopamine. Instead, it will block 5-HT2 receptor. It will block 5-HT2 receptor. Examples are aripiprazole and clozapine. Aripiprazole and clozapine. Side effects. These can block other receptors, and it can cause the side effects because they are blocking the other receptors. So, other receptor block. Which other receptors can it block? It can block muscarinic receptors, it can block histamine receptors like these. Now, in atypical antipsychotics, what are the drugs that are causing obesity? O for obesity, olanzapine. O for obesity, clozapine. Olanzapine and clozapine can cause obesity. Olanzapine and clozapine can cause obesity. Now, weight neutral drugs, these do not cause obesity. What are they? I call it ABCZL drugs. Aripiprazole, brexpiprazole, cariprazine, ziprasidone and lurasidone. ABCZL drugs do not cause obesity. Now, clozapine, this is what is important. It will cause agranulocytosis. That is the reason why I told one drug is contraindicated with clozapine. What is it? It is carbamazepine. Yes, good. So, if there is agranulocytosis, that means absolute neutrophil count is less than 500. For these persons, you need to do regular ANC monitoring. You have to do regular ANC monitoring. ANC means absolute neutrophil count. So, how regularly do you have to do it? For the first 6 months, you have to do it every week. So, you have to do it every week. From the second 6 months, you can do it fortnightly. Fortnightly means after every 2 weeks. After 1 year, you can do it monthly. This is actually the drug of choice for resistant schizophrenia. Resistant schizophrenia. Now, these are the drugs that are causing the QT prolongation. One thing easy to remember, Q for Q is quetiapine. This is about the antipsychotic drugs. Yes. Now, coming to the bipolar disorder. Bipolar disorder means the patient has mania as well as depression. In acute mania, you will use aripiprazole plus lithium plus or minus benzodiazepines. Yes, prophylaxis of mania and bipolar disorder. What is the drug of choice? It is lithium. It is lithium. What is the drug of choice for cyclothymia and rapid cyclers? It is valproate. Now, lithium is also teratogenic. It can also cause Epstein's anomaly. It can also cause Epstein's anomaly. What are the other side effects of lithium? These are hypothyroidism, obesity and diabetes insipidus. Hypothyroidism, obesity and diabetes insipidus. Okay. So, now we are going to start with the antidepressant drugs. That means these are the drugs that are used in a depression. Now, why do people have depression? Whenever the BDNF in the brain decreases, it will cause depression. What is BDNF? Brain derived neurotropic factor. Now, why is this BDNF decreased? This will be decreased whenever serotonin and the norepinephrine are decreased. So, decrease in serotonin and norepinephrine will decrease the BDNF. So, what should be the treatment? You should be able to increase the levels of serotonin and norepinephrine. We will see what is happening to these monoamines. These are monoamines, no. So, what will happen? Both of them are reuptaken. Yes, once they are released into the synapse, they are reuptaken. Okay. Since these are monoamines, these are metabolized by MAO, monoamine oxidase. So, how can you increase the levels of serotonin and norepinephrine? If you block the metabolism, their levels will increase, isn't it? So, if you give MAO inhibitors, they will increase the levels of serotonin and norepinephrine. That is the first class of drugs. Now, if you block this reuptake, that is the second class of drugs. This is known as TCA, tricyclic antidepressants. They will block the reuptake of both serotonin and norepinephrine. Now, we are not using them nowadays because it has lot of side effects. Along with blocking this reuptake, it will also block many other receptors like HAMs. H for histamine blockers. It will also block alpha. It will also block muscarinic receptors. It will also block serotonin receptors. That is why I called it HAMs. So, because of this, we are using some new drugs. These are known as SNRI and SSRI. SNRI means serotonin norepinephrine reuptake inhibitor. Yes, SSRI means selective serotonin reuptake inhibitor. This one is only blocking the serotonin reuptake. This one is blocking both serotonin and norepinephrine reuptake. Yes. Now, coming to the drugs here, we'll go through the first class of drugs. These are MAV inhibitors. In this, I want you to remember one thing, that is phenylazine. If you can remember one more thing, that can be phenylcypromide. Now, what are the side effects of MAV inhibitors? I told you, if you take MAV inhibitors along with cheese, it will cause what? Cheese reaction. It will cause cheese reaction. What is the drug of choice for cheese reaction? It is phentolamine. It is phentolamine. Now, if you use MAV inhibitors, it will increase the serotonin. Increased serotonin will cause serotonin syndrome. Now, what is the drug of choice for serotonin syndrome? It is cyproheptadine. Cyproheptadine. So, what is the drug of choice for serotonin syndrome? It is cyproheptadine. Now, coming to tricyclic antidepressants, these are pramines. You see here clomipramine, desipramine, imipramine and triptylines, amitriptyline and nortriptyline, also doxepine. Nowadays we are not using this much because of its lot of side effects. Now these are alkaline drugs, okay. So these are alkaline drugs, okay. So if these are alkaline drugs, what would be the treatment for the toxicity? If there is toxicity, what would be the treatment? Think about it. Treatment for the toxicity of tricyclic antidepressants. Since it is basic, would you give forced acidic diuresis? Forced acidic diuresis? Don't say yes. No. See, I know for all the basic drugs you will give forced acidic diuresis, but for TCA is the exception. TCA you still give sodium bicarbonate. For TCA you still give sodium bicarbonate. Yes. Now, coming to SNRI, these are duloxetine, desvenlafaxine, milnacipran, levomilnacipran. Now, coming to SSRI, these are fluoxetine, paroxetine, citalopram, escitalopram, yes, depoxetine. Now, at least remember that duloxetine is not SSRI. In SSRI, we have what? Fluoxetine, paroxetine and depoxetine. Duloxetine is SNRI. Now, what are the side effects? We've already talked about MAV inhibitors and TCA side effects. Now we'll talk about side effects of SNRI and SSRI. In both of these drugs, serotonin is increased. Now, when serotonin is increased, it can act on the 5-HT2 serotonin 2 receptor that is present in the brain. Now, when it is acting on the serotonin receptor of the brain, it will cause a transient anxiety attack. Yes, when it acts on the 5-HT2 receptor on the brain, it will cause transient anxiety attack, insomnia and vivid dreams. Now, if it acts on the 5-HT2 receptor that is present on the spinal cord, it will cause problems with the erection. It will cause erectile dysfunction. It can cause anorgasmia and delayed ejaculation. Yes, so that is why depoxetine can be used in premature ejaculation because it delays the ejaculation. Yes, now, if it activates the 5-HT3 receptor, it can cause nausea, vomiting. If it activates the 5-HT4 receptor, it will cause prokinesis. It might sometimes cause diarrhea because of prokinetic effect in the GIT. Now, these are typical antidepressants, 4 classes of drugs. Now we have newer drugs. These are known as atypical antidepressants. In this, at least remember 1 or 2. Trazodone, it will cause priapism. This is the side effect of trazodone. It causes priapism. What I want you to remember is bupropion. It is an atypical antidepressant, but it can be used in smoking dependence. This is a very, very important thing. Now, we have something known as esketamine. This can be used as nasal spray. In depression. Okay. Now, coming to the anti-Parkinson drugs. That means these are the drugs used in Parkinson's disease. Now, what is Parkinson's disease? I've already told you before. This is due to death of dopaminergic neurons in substantia nigra. So, dopamine levels will decrease. So, what should be the treatment? You should increase the dopamine. Now, the drug is levodopa. You will use L-dopa, that is levodopa plus carbidopa. You should avoid it with vitamin B6. Got it? Now, what are the side effects? Because you're increasing dopamine, increased dopamine can cause psychosis. Increased dopamine can cause dyskinesia. This is what I told you in the side effects of antipsychotics, if you remember. Tardive dyskinesia. It is happening because D2 receptor upregulation. Yes, and it can also cause hypersexuality, impulsive gambling and on and off phenomenon. That is what is important. Now, see this table. Everything about dopamine will become easier if you are able to understand this table. See carefully, a person is normal when his dopamine levels are normal. Yes, this is that normal person. Now, let us suppose his dopamine levels are increased. So, if his dopamine levels are increased, it will cause psychosis. So, you can see here patient is having hallucinations and everything, that is schizophrenia, psychosis. So, what is the treatment of psychosis? Yes, you can give typical or atypical antipsychotics. Let us suppose you are giving typical antipsychotics. Typical antipsychotics. Typical antipsychotics are D2 receptor blockers. If you give D2 receptor blockers, what will happen? It will decrease the dopamine and it is supposed to treat psychosis, isn't it? But problem is there are side effects because of this. Side effects because of these. What are these side effects? These are known as EPS, extrapyramidal symptoms. Now, why? I will tell you. I already told you before. Let us suppose this is substantia nigra. In substantia nigra, acetylcholine and dopamine are in almost equal levels. Now, what will happen when you give typical antipsychotics? This dopamine will decrease, but acetylcholine is staying exactly the same. But if you compare both of them, it will look as if acetylcholine is more than the dopamine. But no, what has happened? Only dopamine has decreased, acetylcholine is same, but in comparison, acetylcholine looks more. So because of this acetylcholine, it will cause sudden muscle contraction. Yes, because it is happening suddenly, it will cause sudden muscle contraction of muscles because of acetylcholine. That is what is known as acute dystonia. Acute dystonia. Now, if you see this condition for a long period of time, see, if there is decreased dopamine substantia nigra for a long period of time, this is almost similar to one pathology, that is Parkinson's disease. So, it will also cause drug-induced Parkinson. Drug-induced Parkinson's. Now, in both of these, what is the problem? Acetylcholine looks higher in quantity. If you see here, dopamine will decrease, but acetylcholine is staying same. So, if you see the balance, acetylcholine looks higher. So, what can you do? You can block the muscarinic receptors. That is why you use benzhexol in both of these cases. Did you understand this much? You might ask me, sir, why not increase dopamine? If we increase dopamine, again it will cause psychosis. No. That is why benzhexol is drug of choice in both acute dystonia and drug-induced Parkinsonism. Treatment is benzhexol. Now, if you are using this D2 receptor blockers for a very long period of time, that means you are blocking the receptor for a very long period of time, what will happen? Receptors will undergo upregulation. There are lot of receptors that are coming up. So, even small amount of dopamine can activate many receptors and it will cause a dyskinesia. Dyskinesia. I told you, if dopamine increases, it will cause a dyskinesia. So, here the problem is there are lot of receptors. So, even small amount of dopamine can cause dyskinesia. So, you have to block the release of dopamine. So, you have to block the VMAT2. You have to block the vesicles. VMAT2 blockers. These are tetrabenazine, deutetrabenazine and valbenazine. Did you understand this much? Tetrabenazine, deutetrabenazine and valbenazine. This is what we have already studied in psychosis, that is schizophrenia. Now, the opposite spectrum. Let us suppose if the dopamine decreases. If the dopamine decreases, it will cause Parkinson's disease. This is what I am telling you. If the dopamine decreases, it will cause Parkinson's disease, tremors, bradykinesia, all of these. Now, the treatment for this is levodopa. That means you increase the dopamine. If you increase the dopamine, what is happening? I already told you. You increase the dopamine, it will cause psychosis. This is what is known as levodopa-induced psychosis. Now, what would be the treatment for this? Can you decrease dopamine? No. See, if you decrease dopamine, it will worsen the Parkinson's disease. That is why you will give atypical antipsychotic. It will not block the dopamine receptor. It will block the serotonin receptor. Now, what is that? It is pimavanserin. It is pimavanserin. Pimavanserin. Did you understand this much? When dopamine will increase, it will increase the movements, it will cause dyskinesia. The treatment for this dyskinesia is amantadine. Amantadine. So, pimavanserin, amantadine, these are also very important things to remember. All of these things that I told you in this slide is very important. So, if dopamine is normal, person is normal. If dopamine is increased, it will cause psychosis. If dopamine is decreased, it will cause Parkinson's. Did you understand this? Yes. Now, coming to the other drugs, there are some D2 agonists. These are pramipexole, rotigotine, and apomorphine. Apomorphine is used to rescue from off phase. I told you on phase and off phase. Yes. On-off phenomenon. On-off phenomenon. So, if you want to rescue the person from the off phase, you will use apomorphine. MAO-B inhibitors and COMT inhibitors. These are used to prolong the on phase. Why? Dopamine is metabolized by MAO and COMT. Yes, MAO-B inhibitors are rasagilan and serigilan. COMT inhibitors are entacapone and tolcapone. Both of them will prolong the on phase. Amantadine, now only I told you, it is used in levodopa-induced dyskinesia. Now, what are the side effects? It will cause something known as libido reticularis. That is the side effect of amantadine. Now, coming to the substance abuse disorders. Now, how many substances we have to study? Opioids, alcohol, and smoking. Coming to the opioids, the first drug is morphine. What are the side effects of morphine? It will increase the intracranial pressure. It will also increase the histamine. So, what would be the contraindications? Because ICP is increased, you cannot be using these drugs in head trauma. Since histamine is increased, you cannot use it in bronchial asthma. Yes, pethidine. Now, the side effect with pethidine is serotonin syndrome. So, what are the contraindications? You should not use it with MAO inhibitors. Why? MAO inhibitors will cause a serotonin syndrome. Now, tramadol. Tramadol is an opioid that you already know, but it also has a non-opioid analgesia component. Why is it there? Because of blocking serotonin and norepinephrine reuptake. Because we are blocking serotonin and norepinephrine reuptake, there is non-opioid analgesia. Now, sufentanil is the most potent opioid, remifentanil is the shortest acting opioid. Opioid toxicity. So, in opioid toxicity, how do you treat it? You see the pinpoint pupils. Yes, respiratory depressions in opioid toxicity. In acute management, you will give naloxone. Why? Because it is an opioid antagonist and short acting. For maintenance, you have to give naltrexone. Why? Because it is long acting. Okay, this is long acting opioid antagonist. Now, coming to opioid dependence. Now, you can do replacement. You can also prevent relapse. A replacement means you have to replace opioid with a similar looking drug. That means the actions has to be same, but the addiction potential has to be less. These drugs are methadone and buprenorphine. Let us suppose a person wants to give out opioids, but he is having cravings for it. Now, how do you reduce these cravings? By replacing it, by giving methadone and buprenorphine. But how do you prevent the relapse? How do you prevent the relapse? By naltrexone. By naltrexone. Now, next, alcohol. Alcohol, we have edible alcohol, that is ethanol. Methanol and ethylene glycol should not be consumed. Now, if you consume any of these alcohols, it will cause toxicity. Now, the drug of choice for this toxicity is fomepizole. It is fomepizole. Now, for alcohol dependence, if a person suddenly stops alcohol and he is having withdrawal symptoms, what would you do? You have to give benzodiazepines. Benzodiazepines. Now, for replacement, you have to give long-acting benzodiazepine, that is chlordiazepoxide. To prevent the relapse of alcohol, what is the drug of choice? It is again naltrexone. Naltrexone. So, remember naltrexone, it is very important. Yes, if naltrexone is not available, then you can give acamprosate. If acamprosate is also not available, then you can give disulfiram. If acamprosate is also not available, you can give disulfiram. If you see here, naltrexone, acamprosate, topiramate. Topiramate is not FDA approved, that is why I did not tell you. But all of these things will decrease the craving. Disulfiram will cause aversion. Now, coming to the smoking, what is the drug of choice for smoking dependence? It is varenicline. Yes, what are the other methods of treatment? You can give nicotine patch for maintenance. But let us suppose in between the patch, let us suppose he is having craving. What will you do? You can ask him to take a nicotine gum or lozenge, but better would be nasal spray. Nasal spray. So you give a patch. If there is some problem, he is not able to resist it, you can ask him to take a nasal spray. If that is not available, nicotine gum or lozenges. Now, there is one more antidepressant that can be used in smoking dependence, that is bupropion. So that's all about the CNS. Now, we are going to start with endocrinology. This is a pretty simple chapter, so we'll go through it as soon as possible. The first one is going to be about the anti-diabetic drugs. These are the drugs used in diabetes. Now, diabetes, we know there are two types, type 1 diabetes mellitus, type 2 diabetes mellitus. In type 1 diabetes mellitus, there is autoimmune destruction of beta cells of pancreas. So, there is no release of insulin. So, what should be the treatment? You have to give insulin. How can you give insulin? Through subcutaneous route. But what is the most common site of administration of insulin? This is going to be in the abdomen. Now, what are the types of insulins that you know? See, according to the textbooks, there are only two types, short acting and long acting. But I've divided into 2 to 3 groups. Let us see how. Short acting, you have lispro, aspart, glulysin as well as regular insulin. But lispro, aspart, glulysin are fast acting, regular insulin is slow acting. This is how I divided it. Now, coming into the long acting, I've again divided into 2, intermediate and long acting. See, in intermediate acting, NPH and lentil. In long acting, you have detamir, glargine and degludec. The longest acting insulin is degludec. Now, we also have a ultra fast acting insulin, that is what is nasal insulin. It is Afrezza. This is the latest insulin. Got it? Where is this regular insulin used? This regular insulin is generally used in type 1 diabetes mellitus. Yes, and it is also used in diabetic ketoacidosis. It can also be used in pregnancies. Yes. Now, what are the side effects of this? Obviously, when you give insulin, sugar levels are going to decrease. This will cause hypoglycemia. Yes, along with glucose, potassium will also go inside the cells. So, potassium in the blood will decrease. That is what is known as hypokalemia. And it can also cause lipodystrophy. That is the reason why you have to alternate the sites of injections with insulin. Now, coming to the type 2 diabetes mellitus, the problem here is insulin resistance. So, here we can give 2 types of drugs. One, that is increasing the secretion of insulin. The others are drugs acting via other mechanisms. So, first group, before seeing this first group, so let us see when you are having food, what happens. Yes, see, you are having a meal. So, this meal comes into the small intestine, and when this glucose and the meal is in the small intestine, it will stretch the intestine. Yes, when this stretches the intestine, what will happen? It will release GLP-1 and GIP. As you already know, in the pancreas, we have beta cells. They will have receptors for GLP-1 and GIP. So, what will this GLP-1 and GIP do? They will act on their receptors and it will cause production of insulin. Now, what will the insulin do? Insulin will act on the cells and it will cause expression of GLUT4 receptors. Usually in the cells, GLUT4 receptors are present inside, but when insulin acts, it will cause GLUT4 receptor. When insulin acts on the cell, it will cause GLUT4 receptor expression. So, what will happen now? This glucose will be absorbed into the blood. Yes, and from the blood, it will be taken into the cells via this GLUT4 receptor. Why is all of this happening? It is because of the insulin release. But how is insulin released? Because of stretching of intestine. Now, this will release GLP-1 and GIP. So, did you understand this? So, if you give GLP-1 analog, will it release insulin? Yes. If you give GIP analog, will it release insulin? Yes. So, these are the drugs that are releasing the insulin. So, this is what is happening in the postprandial period. Now, what is happening when the person is not eating anything? How is basal insulin released? See, about this, I've talked so many times in the classes and I've also made a small Instagram reel and YouTube clip on this. You can watch this quickly. Yes, you will see the mechanism of action of sulfonylureas and meglinides. meglitinides, and you also see how the insulin is released. So I'm not going to repeat it because it has been done so many times. So drugs that is increasing the release of insulin. What are these drugs? I've already told you. You can give GLP-1 agonist. These are glutides. Liraglutide, albiglutide, dulaglutide and semaglutide. These will cause weight loss. Now, if you see, GLP-1 is metabolized by something known as DPP-4. If you see, GLP-1 is metabolized by something known as DPP-4. So, if you block this DPP-4, will GLP-1 increase? Obviously, that is why the other class is DPP-4 inhibitors. These are gliptins. Which gliptins? Sitagliptin, vildagliptin, dapagliptin and linagliptin. Now, all the gliptins are not safe in renal failure except linagliptin. Linagliptin is renal safe. This is what I want you to remember. Linagliptin is renal safe. Now, we have one more thing, that is GLP-1 and GIP agonist. It is having dual action. This is what is tirzepatide. It is having tirzepatide. Two actions, so tirzepatide. T for 2. Got it? So that's all. About the sulfonylurea and meglitinides, I've already asked you to watch that reel where I've explained everything very carefully. Yes, these will block the ATP dependent potassium channels. So it will release the insulin. Now, in sulfonylureas, first generation are chloropropamide and tolbutamide. It has lot of side effects, so not generally used. Coming to the second generation, these are glyburide, glimepiride and glyclazide. Yes, glyburide, glimepiride and glyclazide. Now, meglitinides are neteglinide, repaglinide. So, you will see the name glinide in their names. Did you understand this? This is the first class of drugs that increasing the release of insulin. Now, I have already written here sulfonylurea's first generation is chloropropamide. Now, what are the side effects? It will increase ADH, but most important is it will cause disulfiram-like reaction. What about tolbutamide? It follows zero order kinetics. Tolbutamide, it follows zero order kinetics. Now, coming to the other class of drugs. One is alpha glucosidase inhibitor. Alpha glucosidase inhibitor. When you're having a meal, obviously you'll have complex carbohydrates like starch. Starch has to be converted into simple carbohydrates. How is this happening? With the help of alpha glucosidase. Now, if you block this, this starch will not be converted into simple glucose, so it will not be absorbed into the blood. So what will happen? This starch will come directly into the gut. So gut bacteria will eat up this starch and it will cause flatulence. Yes, it will cause flatulence. Since starch is osmotic, it will also pull the water along with it and it will cause diarrhea. This is known as osmotic diarrhea. This is known as osmotic diarrhea. Since it is glucosidase, the drug names are acarbose, voglibose and miglitol. Acarbose, voglibose and miglitol. Then you have a amylin analog, that is pramlintide. Next is thiazolidine diones. Now, they will activate PPAR gamma receptor. The drug names are glitazones, rosiglitazone and pioglitazone. So, what are the side effects? Pretty common mnemonic. Rosi breaks your heart, so it is cardiotoxic. Some glitazones will also cause bladder cancer. Next are biguanides. Biguanides means metformin. Now, metformin is the drug of choice in type 2 diabetes, as all of you know. What are the side effects that you can see with metformin? You can see acidosis, lactic acidosis. Sometimes it can also cause a megaloblastic anemia. Yes. Now, SGLT2 inhibitors, we have discussed so many times in CVS also. I told these are gliflozins. Along with sodium, glucose will also flow in the urine. So, glucose levels in the body will decrease. Dapagliflozin, empagliflozin and canagliflozin. What are the side effects? Because glucose is in the urine, it will cause UTI. And sometimes it might also cause bone fractures. Yes, that's all. So, there are some drugs that are causing weight loss. I have already told you about one of them. That is GLP-1 analog. It will cause weight loss. Amylin analog, pramlintide. Metformin, yes. SGLT2 inhibitors, it will cause weight loss. How can you remember this? When you play games, you will lose weight, isn't it? So, this is how you can remember. GLP-1 analog, amylin analog, metformin and SGLT2 inhibitor. Now, GLP-1 along with GIP is tirzepatide, that will also lose weight. Got it? Weight gain. Whenever there is release of insulin, it will cause weight gain. Sulfonylureas, it will release insulin. Yes. Insulin, yes, it will cause weight gain. Weight gain. Thiazolidine diones will also cause weight gain. So how can you remember? If you sit, it will cause weight gain. Yes, that's all. Sulfonylureas along with meglitinides. Meglitinides will also release insulin. So this will also cause weight gain. That's all. Now, what are causing the hypoglycemia? When insulin is released, it will cause hypoglycemia. What are releasing insulin? Sulfonylurea and meglitinides along with insulin. They will cause hypoglycemia. That's all. Pretty simple. Now, coming to the chapter of growth hormone. Growth hormone, if it is decreased, it will cause dwarfism. Increased, it will cause acromegaly. So, if growth hormone is decreased, what is the treatment? You have to increase the growth hormone. So, first we will see there is something known as growth hormone releasing hormone analogs. These are morelin, sermorelin, massimorelin, tesamorelin. Yes, sermorelin, massimorelin, tesamorelin. Next are growth hormone analogs. They look exactly like growth hormone. So these drugs are somatram and somatropin. What are the side effects? If growth hormone increases, it will cause carpal tunnel syndrome and hyperglycemia. Carpal tunnel syndrome and hyperglycemia. Yes. Next is IGF-1 analog. It is insulin-like growth factor 1 analog. What are the drugs? Mecasermin. What is mecasermin rinfabate? It is IGF-1 plus IGF binding protein analog. Yes, what is the side effect? Because it is insulin-like growth factor. What will insulin cause? It will cause hypoglycemia. This is what I want you to remember. IGF-1 will cause hypoglycemia. GH will cause hyperglycemia. Next, coming to the acromegaly. Acromegaly means growth hormone is increased. How can you decrease the growth hormone? By giving somatostatin. Yes, why? Because it is a growth hormone inhibiting hormone, somatostatin. Yes, now, what are somatostatin analogs? Octreotide, lanreotide and paceriotide. It is given in the name. Somatostatin is octreotide, lanreotide and paceriotide. What are the uses of octreotide or somatostatin analogs? Somatostatin. See, somatostatin, SOMA, these are the uses. S for secretory diarrhea, O for esophageal varices, M for malignancies, A for acromegaly. That is why we are using it in acromegaly, isn't it? Now, why is it used in malignancy? Because it will decrease both insulin and glucagon. Now we have a growth hormone receptor antagonist, that is what is known as pegvisomant. This is used in resistant acromegaly. Okay. Now, coming to the posterior pituitary gland. What are the hormones that are released from the posterior pituitary gland? Oxytocin and dopamine. So, oxytocin is drug of choice for augmentation of labor. At least this much you know. Augmentation of labor, postpartum hemorrhage. And in breast engorgement also you can use oxytocin. Okay. Now, dopamine agonists are bromocriptine and cabergoline. These are drug of choice in hyperprolactinemia. Very important. Even though these are two lines, please remember it. Hyperprolactinemia, bromocriptine and cabergoline. Now, coming to the thyroid gland. Pretty simple. Thyroid gland. Thyroid hormones are increased. That will cause hyperthyroidism. In hyperthyroidism, we will use drugs like thioamides. Thioamides are TPO inhibitor. Thyroid peroxidase inhibitor. What are the drugs? Carbimazole and methimazole. Carbimazole is a prodrug. It is converted into methimazole. Now, what is the drug of choice for hyperthyroidism? Obviously, it is this drug carbimazole and methimazole. Now, can you use this drugs in the pregnancy? No. Why? Because it has a side effect. It has a side effect called aplasia cutis. Aplasia cutis, and it can also cause conal atresia or esophageal atresia also. Conal atresia and esophageal atresia also. These are teratogenic effects, no? So you cannot use them in pregnancy. So in the first trimester of pregnancy, you should use propyl thiouracil, PTU. So it is given P for P, पहले trimester. पहले trimester में क्या use करना चाहिए? It is PTU. So drug of choice for hyperthyroidism in first trimester is PTU. Will you continue for the second and third trimester as well? Because it is having less teratogenic effects. No, you should not continue. Why? Because this is hepatotoxic. So you will use it only in the first trimester, but again in second and third you will use carbimazole, methimazole. Why? By the second and third trimester, organogenesis is mostly done. That is why we can use it in second and third trimester. Now, next drugs are secretion inhibitors. These are 5% Lugol's iodine and 10% potassium iodide. These are fast-acting anti-thyroid drugs. Yes, so they can be used before surgery to decrease the vascularity and the size of the gland. This is about the Lugol's iodine and potassium iodide. Now, coming to thyroid storm. In thyroid storm, you will have atrial fibrillation. If you remember atrial fibrillation, I told you for rhythm control and rate control, I told you drugs. For rate control, what are the drugs we are using in atrial fibrillation? Beta blocker, calcium channel blocker and digoxin. That is why the drug of choice here is beta blocker. But if they ask you anti-thyroid drug of choice for thyroid storm, it is going to be PTU, propyl thiouracil. It is going to be PTU, propyl thiouracil. Let us suppose a person is having hypothyroidism. That means thyroid hormones are reduced. What you should do? Thyroid hormone replacement. Okay, leothyronin is T3, levothyroxine is T4. So this is the drug of choice in hypothyroidism. This is the drug of choice in hypothyroidism. That's all. Now, adrenal gland secretes cortisol, steroids. Yes, cortisol is steroid. So, you know many steroids that will cause inflammatory disorders. Okay. What are the uses of steroids? See, main use I want you to remember is it is used for surfactant maturation in preterm labor. Now, what is the dosing for this? You have to give 24 mg in 48 hours. 24 mg in 48 hours to the mother. Now, we can give two steroids. What are they? B and D. Betamethasone, dexamethasone. Since betamethasone is a second letter, see here betamethasone. It is second letter, you will give 2 doses. Dexamethasone is fourth letter, so you will give 4 doses. So, if you have to give 24 mg in 2 doses, what will be the betamethasone dosing? It is 12 mg, 2 doses, 24 hourly. Now, coming back to dexamethasone, if you have to give 4 doses, it should be 6 mg. Yes, 6 mg, 4 doses you have to give 12th hourly. That will make it 48 hours. Understood? That is about betamethasone and dexamethasone. Now, what are the side effects of this? It will cause centripetal obesity. It will also cause proximal myopathy. That is what gives you lemon on stick appearance. So, basically, if you use steroids for long period of time, it will cause Cushing syndrome. And it will also cause diabetes mellitus, osteoporosis, and severe use of steroids for a very long period of time will cause avascular necrosis. It will also cause hair loss, and in the eyes, this is important to remember, it will cause posterior subcapsular cataract. Posterior subcapsular cataract. Yes, chloroquine also causes this. Chloroquine also causes the vortex keratopathy or cornea verticillata. Yes, posterior subcapsular cataract. Please remember this. Yes, now, if you use steroids for a long period of time, it will suppress the HPA axis. So, to prevent this, what you should do? You should use low doses of steroids when possible. If not, if you are using high doses of steroids, when you are stopping, you should taper the steroids. You taper the dose of steroids and then stop. Yes, that's all. Now, coming to osteoporosis. Osteoporosis, what could be the treatment? You can either block osteoclast or you can activate osteoblast. Now, how do you block osteoclast? With the help of drug called bisphosphonate. So, you see here bisphosphonates. These are dronate drugs. Alendronate, risendronate, zolendronate. Zolendronate is IV. Now, it is blocking the osteoclast by causing apoptosis. Apoptosis means death. What are the side effects? It will cause osteonecrosis of jaw. And dronates. AIDS means these are acidic drugs. So, if they are in the esophagus, it can cause esophagitis. So, how do you prevent it? How do you prevent it? You should ask the patient to take the tablet with full glass of water. Full glass of water. And you should ask the patient not to lie down at least for 30 minutes. Don't lie down at least for 30 minutes. Why? 30 minutes is the gastric emptying time. By 30 minutes, the drug might have passed from the gastric into the small intestine. So, it will not come back. Yes, preferably on empty stomach. If the patient is on empty stomach, it would be even better. Now, PTH analog is teriparatide. It will activate the osteoblast. There is one more drug, strontium granulate. It will block osteoclast and it will activate osteoblast, but it is not used because it has lot of side effects. It has lot of side effects, many side effects. Yes. So now we'll start with the drugs acting on the reproductive system. First, we'll see the female reproductive system drugs. Yes, these are going to be GnRH analogs. Now, when gonadotropin releasing hormone is released, it will act on the pituitary gland. It will release LH and FSH. This much you already know. Now, what is GnRH analog? That is gonadorelin. Now, we can give GnRH agonists. What are these? Goserelin, buserelin, histarelin, nafarelin and leuprolide. Gonadorelin is GnRH analog. GnRH agonist is relins, goserelin, buserelin, all these relins. Okay. Now, here listen carefully. If GnRH, yes, how is it released in the body? Pulsatile. When it is released in a pulsatile manner, it will increase LH and FSH. That much you already know. So, if you give GnRH agonist in an intermittent dosing, it is similar to pulsatile, no? So, it will increase LH and FSH. Yes, that's all. That is why it is used in delayed puberty. Now, if you give continuous dosing, what will happen? First, it will increase LH and FSH, but after a period of time, continuous stimulation of receptors will cause receptor down regulation. So, it will reduce the LH and FSH. So, if you are given a continuous dosing, in the long term, it will reduce LH and FSH. That is why it can be used as a GnRH antagonist as well. Yes, so it is used in precocious puberty, endometriosis, fibrosis and ER-positive breast cancer. But the problem here is, it will cause a flare-up reaction. Let us suppose a person is having pain because of endometriosis. If you give GnRH agonist in a continuous dosing, first the pain will increase because LH and FSH is increased and it will increase the estrogen, but after some time this will decrease. That increasing in pain is what is known as flare-up reaction. To prevent this, we have made GnRH antagonists. These are Abarelix, Cetrorelix, Dagarelix and Ganirelix. Yes, now we also have a tablet that is Elagolix. Elagolix. That's all about the GnRH analogs. Now coming to the estrogen compounds, we have something known as SERMs. Selective estrogen receptor modulator. Yes, because estrogen receptors are present on many organs. Yes, you want to increase or decrease the effect in certain organs. That is why we have made SERMs. Yes, so in this I want you to remember tamoxifen, raloxifene and clomifen. Next is SERD, selective estrogen receptor down regulator. That is fulvestrant and elacestrant. Next is aromatase inhibitor. What is aromatase inhibitor? See, in postmenopausal females, testosterone is converted into estrogen with the help of an enzyme called aromatase. So, if you block this aromatase, estrogen will not be formed. All of these are anastrozole and letrozole. Now, I want you to remember these drugs, that is fine. But what are the uses of these drugs? We will see. See, if a person is having ER-positive breast cancer, if a woman is having ER-positive breast cancer, and if the woman is premenopausal, which drug would you use? Tamoxifen. If the female is postmenopausal, you would use letrozole. Now, suppose the woman is a postmenopausal woman with ER-positive breast cancer and having osteoporosis, that is when you use raloxifene. That is where you will use raloxifene. These are the uses of these tablets. Okay. Now, coming to PCOD. PCOD, the woman has irregular cycles. The drug of choice for irregular cycles are OCP. She will also have insulin resistance. The drug of choice is metformin. She will also have anovulatory cycles. Because of this, it will cause infertility. Now, which drug will you use here? It is supposed to be letrozole. Yes, now, coming to the anovulatory infertility without PCOD. She has anovulatory infertility, but this time she does not have PCOD. Here you can use clomiphene. Now, short words about contraception. For contraception, you can use combined OCPs. Progesterone only pills, or for emergency contraception, you would use levonorgestrel, that is has to be used within 72 hours. Now there is one more drug called ulipristal that can be taken within 5 days. Ulipristal can be taken within 5 days. Now in progesterone, I just want you to remember one drug, SPRM, selective progesterone receptor modulator, that is mifepristone. Mifepristone will block the progesterone receptors in the endometrium. That is why it is the first line drug in abortion. So if you want to cause abortion, you will give mifepristone. Mifepristone will cause detachment of the embryo from the uterus. Yes. Now, then you give misoprostol. What will misoprostol do? It will do contraction of uterus and the embryo will come outside. Did you understand this much? This is about the abortion. This is what is done in the first trimester abortion. Yes, that's all. These are the uses I want you to remember. Now we will start with gastrointestinal tract. It is a pretty small chapter. It would maybe take 5-7 minutes to finish this. The first one is peptic ulcer disease. So the treatment of peptic ulcer disease, it is either PCM or PCA. What do you mean by PCM and PCA? See, P for proton pump inhibitors, C for clarithromycin, M for metronidazole. That is what is PCM. Now coming back to PCA, proton pump inhibitors, clarithromycin, amoxicillin. That is what is PCA. So you change the metro with amoxicillin, that becomes PCA. So you see here, you are giving 1 PPI and 2 antibiotics. Why? Because peptic ulcer disease is caused by Helicobacter pylori. Helicobacter pylori. Because peptic ulcer disease is caused by Helicobacter pylori. Now coming to these PPIs, we look at these. These are protein pump inhibitors. Next, the drug is omeprazole. It is a CYP2D6 inhibitor. Now CYP enzymes, if it inhibits, what will happen? Metabolism will decrease and it will increase the effect of those drugs. Antipsychotics and antidepressants are metabolized by CYP2D6. So if you are blocking this, toxicity of these drugs will increase. That is what is written here. Now CYP2D6 is also required for activation of tamoxifen. If you are blocking CYP2D6, there is no activation of tamoxifen. Yes. Now we have one more new class of drugs. These are known as potassium competitive acid blockers, PCAB. Potassium competitive acid blockers. On the proton pump, you have H plus coming out and the potassium going in. So this will block the potassium channel that is present on the proton pump. Yes. Now the drug names are vonoprazan and reveprazan. These are faster acting than PPIs. This is something that you can remember. H2. If you are blocking the H2 receptors, this will also decrease the acid production. The important one is cimetidine. Why? Because it has a lot of side effects. Can be asked in the exam, that is gynecomastia. Yes, you must have studied the disco drugs. Yes, in disco, C is for cimetidine. It will cause gynecomastia. Next are bismuth compounds. Bismuth compounds will cause black discoloration. It will cause black discoloration of stool and tongue. Of stools and tongue. Yes. Now, bismuth subsalicylate can cause race syndrome. It can also cause a race syndrome. This one we have already talked about it in the outerwears chapter. Now, coming to antiemetics, that means these will decrease the vomiting. This will decrease the vomiting. Now, 5-HT3 receptor will cause vomiting. So, if you block it, it will decrease vomiting. 5-HT3 receptor blockers will decrease vomiting. What are they? These are cetrons. Ondansetron. Ondansetron is actually drug of choice for early onset chemotherapy induced nausea and vomiting. Early onset chemotherapy induced nausea, vomiting. For late onset chemotherapy induced nausea and vomiting, it is aprepitant. It is aprepitant. Now, what is the drug of choice for morning sickness? It is doxylamine plus vitamin B6. Now, we've already studied this. What is the drug of choice for motion sickness? It is supposed to be scopolamine. It is supposed to be scopolamine. Now, coming to the prokinetic drugs. What are prokinetic drugs? This will increase the movement of the gastrointestinal tract. Yes, so these are prokinetics, increasing the movement. Now, in this we have 5-HT4 receptor agonist like cisapride and tegaserod. Now, these are banned because it will cause QT prolongation. Now, after this we have D2 blockers. If you block D2, that will also cause prokinesis. Now, what I wanted to remember is there are two drugs, metoclopramide and domperidone. Domperidone, D for D, it only or maximally blocks D2. Metoclopramide, it will block D2, 5-HT3 blocker as well. So, it will decrease the vomiting. So, it is an anti-emetic as well. This is what I want you to remember. And it is also prokinetic because it activates 5-HT4 plus also. Now, since it is a D2 blocker, we have studied in CNS, it will cause extrapyramidal symptoms and hyperprolactinemia if it crosses the blood-brain barrier. This will cross it, so it will cross all of these side effects. What are the side effects of these drugs? EPS and hyperprolactinemia. Now, domperidone will not cross the blood-brain barrier, so you see minimal EPS or no EPS. Yes, that's all about the gastrointestinal tract. So now we are going to start with the antimicrobials. Antimicrobials means these are the drugs acting against microbes. So what are the microbes that we know? These are bacteria, fungi, viruses and protozoa. So this is what we are going to discuss: antibacterials, antifungals, antivirals, antiprotozoals. So first we will start with the antibacterials. Now, if you know the structures of bacteria, you know the classes of antibacterials. Let us see how. So the outermost structure of the bacteria is cell wall, and then inside you have cell membrane, and these round structures are ribosomes, and this is what is nucleoid. So if you want to break the bacteria or kill the bacteria, what you should do? You have to break the structures of the bacteria. So let us see. If we are breaking cell wall, these are known as cell wall synthesis inhibitors. These are first class of drugs. Second is cell membrane inhibitors, second class of drugs. Third class, in the ribosomes, what is happening? Protein synthesis. So we are blocking the protein synthesis. These are known as protein synthesis inhibitor. This is the third class of drug. Now, coming to the nucleoid. Inside the nucleoid, we have DNA. For formation of DNA, we require folate. So you can block folate. These are folate inhibitors. Yes. Now, for repairing of DNA, we have something known as DNA gyrase. You can block this also. So these are the 5 classes of drugs. That's all. Cell wall synthesis inhibitors, cell membrane inhibitors. Next are protein synthesis inhibitors, folate inhibitors, and DNA gyrase inhibitors. Now, how do these antibiotics work? It can work via 2 mechanisms, either static or cidal. Cidal means it is killing. Static means it will stop replication of bacteria. It will stop the replication of bacteria. This is the meaning of static. That's all. So there are these 5 classes: cell wall synthesis inhibitors, cell membrane inhibitors, protein synthesis inhibitors, folate inhibitors, and DNA gyrase inhibitors. Now, how to remember which are static and which are cidal? Now, how to remember this? See, to stop aging of your skin, what do you generally apply? You apply SPF. No, that is what is sunscreen. So see here carefully. S means static, P means protein synthesis inhibitors, F means folate inhibitors. So protein synthesis inhibitors and folate inhibitors are static. That's all. All the remaining drugs are cidal. Now, we have some exceptions in this. We'll study in their respective classes, but easy way to remember is SPF. What are static? Protein synthesis inhibitors and folate inhibitors. Yes, we are done with the classes. Now, first let us start with cell wall synthesis inhibitors. In cell wall synthesis inhibitors, the first class of drug that we have is beta-lactam. How does it work? It works by blocking the cross-linking. That is what is known as transpeptidase. Yes, in this we have penicillins, cephalosporins, carbapenems, and monobactams. So you can write it or remember it as PCM. So P is for penicillin, C is for cephalosporin and carbapenem, M is for monobactam. That's all. So these are the drugs in beta-lactams. So first let us start with penicillins. What is the drug of choice in neurosyphilis? It is penicillin G. This is the aqueous form. Now, if you remember benzathine penicillin G, it is used in rheumatic fever prophylaxis as well as syphilis treatment. These are two important things that you need to know about penicillins. Now, coming to Jarisch-Herxheimer reaction. Do you know what is this? You must have studied in microbiology, Jarisch-Herxheimer reaction. When you give penicillin to a person who is having syphilis, what will happen? It might cause worsening of the skin lesions. Yes, it might cause fever, myalgia, decreased BP, increased heart rate. Why is this happening? This is happening because of spirochete lysis. Why syphilis is due to spirochetes. Now these spirochetes will start dying and it will produce a immune response. It will cause cytokine release. That is why you see all of these things. That is what is known as Jarisch-Herxheimer reaction. Yes, now we will see about the resistances in the penicillin. Now we have something known as methicillin resistant Staphylococcus aureus. Now what is the drug of choice for MRSA? It is supposed to be vancomycin. The drug of choice for MRSA is vancomycin. Now, if the bacteria becomes resistant to vancomycin itself, it is known as VRSA. Now, what is the drug of choice for VRSA? It is daptomycin. But if you see VRSA pneumonia, that means if there is a pneumonia that is caused due to vancomycin resistant Staphylococcus aureus, can you give daptomycin? No, you cannot give daptomycin because lungs have surfactant and surfactant inactivates this daptomycin. So, in the lung you have to give linezolid. L for L, remember it this way. L for L. In the lung you will give linezolid. That's all. MRSA, vancomycin. VRSA, daptomycin. VRSA in lungs, linezolid. That's all. Now, if you see in the penicillins, maslocillin, azlocillin and piperacillin. Yes, all of these are effective against Pseudomonas. But what is important is vancomycin is not effective against Pseudomonas. Please remember this much. Vancomycin is not effective against Pseudomonas. That is what I want you to remember. Now, coming to cephalosporins. Cephalosporins, the drug of choice in Pseudomonas is ceftazidime. It is ceftazidime. For typhoid, it is ceftriaxone. And in the surgical prophylaxis, you will give cefazolin. So, ceftriaxone is a third generation. Cefa means cef is given, that is a cephalosporin. A means the first letter, so this is the first generation. Now, cephalosporins are usually not given in renal failure because they can aggravate the renal failure and because these cephalosporins are excreted through kidney. Now, if you see here, there are some drugs that are being excreted in bile as well. These are ceftriaxone and cefoperazone. If they are excreted in bile, they will go into the intestine and they will be excreted through feces. That is why these are safe in renal failure. Now, there are some cephalosporins that will cause disulfiram-like reaction. This we have studied in the CNS. What is it? Cefoperazone, cefotetone and cefomendol. When there is disulfiram-like reaction, it will cause increased heart rate, it will cause palpitations, it will cause anxiety-like symptoms and all of these. You see all of these with disulfiram-like reactions. These are the drugs that cause it. Most important drug that is usually asked in the exam is metronidazole. We'll talk about it when we are studying metronidazole. But what I want you to remember is metronidazole will also cause this disulfiram-like reaction. So, that's all about the cephalosporins. Now, coming to the next class, that is carbapenems. In carbapenems, I just want you to remember one word, that is cis. Cis means, C for carbapenems, this much you already know. I for imipenem. Now, what are the side effects of imipenem? S for seizures. It will cause seizures. Now, imipenem is metabolized by something known as renal DHP, that means renal dihydropeptidase. This will inactivate imipenem. If you want to block renal DHP, which drug would you give? You will give cilastatin. Yes, why? Because cilastatin will block the renal DHP and it will increase the effect of imipenem. That's all. So, this is what I want you to remember. Okay, so you see here side effects of carbapenem are seizures. That is why it is contraindicated in epilepsy. Now, these seizures are maximum in imipenem. That is why I gave you the mnemonic cis. That's all, it finishes carbapenems. Next is monobactam. Now, why are these known as beta-lactam antibiotics? Beta-lactam antibiotics. All of them have beta-lactam ring and it also has a side chain. Now, in monobactam, it only has one ring, it only has beta-lactam ring. It has only beta-lactam ring. There is no side chain. Now, all these three drugs have side chain. Because of side chain, it causes penicillin allergy. It causes penicillin allergy. So, if a person is allergic to penicillin, he will also be allergic to cephalosporins, he will also be allergic to carbapenems. Why? Because there is side chain in all three of them, but there is no side chain in monobactam, so it will not cause allergy. That is why it is known as no cross allergy with penicillins. So they will ask you in the question which beta-lactam has no cross allergy. That is what is monobactam. It is also, the drug name is astrionam. It is drug name is astrionam. That's all. Done. Now we are done with beta-lactams. Next class is glycopeptides. In glycopeptides, we have something known as vancomycin. What are the side effects of vancomycin? It will cause red man syndrome. Red man syndrome. You can see in the name itself, N for nephrotoxicity, O for ototoxicity. It will cause nephrotoxicity and ototoxicity. Now, the other classes of drugs are bacitracin, cycloserine and phosphomycin. Phosphomycin. Bacitracin can be used in MRSA nasal carriers. Cycloserine, what are the side effects? S for seizures. It will cause seizures. Cyclo, it will also cause psychosis. You can remember it as psychosis. That means psychoserine. Yes, instead of cycloserine, you can remember it as psychoserine. So, psycho means psychosis, serine, SE for seizures, that's all. Phosphomycin can be used in UTI. These are all cell wall synthesis inhibitors. Only in beta-lactams you have four classes. What are they? Penicillin, cephalosporin, carbapenem and monobactam. So, you can remember it as PCM, that's all. Now, coming to cell membrane inhibitors, we have two of them. What is most important to us is daptomycin. Daptomycin is drug of choice for MRSA. This much you already studied. Now, there is a superbug that is known as NDM1 beta-lactamase. NDM1 beta-lactamase, for this the drug of choice is colistin. This is also cell membrane inhibitor. So, remember colistin and daptomycin in cell membrane inhibitors. So, we are done with cell wall synthesis inhibitors, cell membrane inhibitors. Next is protein synthesis inhibitors. Protein synthesis inhibitors. Now, where do protein synthesis happen? Where does protein synthesis happen? In the bacteria, it happens in ribosomes. Now, how many subunits do we have in the ribosomes? It is 30S and 50S. It is 30S and 50S. Now, I told you a very good story in the class to remember all of these subunits and how to remember the drug classes and how to remember the mechanism of actions. Yes, now we don't have enough time to do all of that, but I'll give you a quick recap. Yes, let us see. Drugs acting on 30S, I asked you to remember as 80 drugs. Yes, drugs acting on 50S, I asked you to remember it as OCPMLS. OCPMLS. We will see what all of these are. Yes, 80. Drugs acting on 30S subunit, A for aminoglycoside and T for tetracycline. Okay, I told you protein synthesis inhibitors are SPF. It is static. SPF you get in 30 and 50 concentration. No? So, you can easily remember SPF 30 and 50 protein synthesis inhibitors are acting either on 30S or 50S. This is how you can remember. In 30S you have ANT, in 50S you have OCP MLS. Now, in the 30S, coming to aminoglycosides. Aminoglycosides act by misreading of mRNA. So, it will cause production of abnormal proteins. These are toxic to cells and they will kill the cells. So, only drug that is cidal in protein synthesis inhibitors are aminoglycosides. These are cidal. They will have the name mycin in them. Mycin, amikacin, gentamicin, streptomycin, kanamycin, all the mycins are aminoglycosides. What are the side effects of this? You see here carefully, again it is given in the name amino, N and O. It will cause nephrotoxicity, it will cause ototoxicity, and N and M, it will cause neuromuscular toxicity. It will cause neuromuscular toxicity. Maximum nephro and neuromuscular toxicity is caused by neomycin. It is given in the name itself, neomycin, N for N. So this is about aminoglycosides. I want you to remember. There is a drug called streptomycin. Streptomycin is drug of choice in rabbit fever. What is rabbit fever? It is tularemia. It is tularemia. That's all. Now, coming to the tetracyclines. Tetracyclines block the A site. I asked you to remember A and T. So, tetracyclines will work by blocking the A site. This is how you can remember. Now, what are the drugs in tetracyclines? All the cyclines are tetracyclines. Yes. So, any drug you see by the name cyclines are tetracycline. Doxycycline, minocycline, tetracycline, oxytetracyclines, all of these. Now, how do we remember the side effects? I told you, you remember it with A, B, C, D, E, F. These are the side effects. With A, it will cause acute renal failure. Acute renal failure. Now, B, it blocks the bone growth. It blocks the bone growth. With C, it will cause catabolism. D, diabetes insipidus. E, ear dysfunction. Ear dysfunction. What is important in all of this is F. F, it is Fanconi syndrome. F, it is Fanconi syndrome. How do you have Fanconi syndrome? Whenever you take an expired tetracycline, it will cause Fanconi syndrome. Please remember this. Now, in acute renal failure, which tetracycline is safe? They will ask you. That is doxycycline. Doxycycline is safe in acute renal failure or patient with renal failure. Which tetracycline can you use? You can use only doxycycline. Now, coming to the drugs acting on the 50S, these are OCP, MLS. First, we will see MLS drugs. M means macrolide, L means lincosamide, S means programmine. Now, all these drugs will block something known as translocation. All these drugs will block translocation. If you see here carefully, macrolides, these are macro. So, this is azithro. The drug is azithromycin, macrolide, azithromycin. Now, macrolide, remember this, macro, RO, azithromycin, RO. Romycins are macrolides. Mycins are aminoglycosides, but romycins are macrolides. Yes, easy way to remember this. Now, so what are the side effects of macrolides? It is given in the name itself. You can see macro. Macro is the side effect. Now, what is important in this macro? Not everything is important for us. In macro, at least remember R and O. It will cause reversible ototoxicity. It will cause reversible ototoxicity. This is about macrolides. Yes. Now, coming to lincosamides. See here, CLIN. It was clindamycin. What is the important side effect of clindamycin? It will cause something known as pseudomembranous colitis. It will cause pseudomembranous colitis. Now, you tell me, what is the drug of choice or the best drug for pseudomembranous colitis? It is fidaxomicin. It is fidaxomicin. Now, what is the important side effect of clindamycin? It is pseudomembranous colitis. The drug of choice is fidaxomicin. Coming to streptogamins, we have two drugs, that is vinpristin and dalfopristin. Vinpristin and dalfopristin. How can you remember this? You can remember it with the easy mnemonic DQS. That is Dulkar Salman. No, D for dalfopristin, Q for quinpristin, S for streptogamins. These are streptogamins. Yes, MLS is done. It is blocking the translocation. Now, coming to OCP. OCP means oxazolidinones. Yes, it blocks the initiation. C and P, chloramphenicol, fluoromutilins. They will block peptidyl transferase. Yes. Now, what is oxazolidinone? It is linezolid. It is linezolid. What are the side effects of linezolid? Not really important, but one thing I want you to remember is it can cause cheese reaction. It can cause cheese reaction. Why? Because it is a MAV inhibitor. It will cause cheese reaction. Drug of choice for cheese reaction, I already told you, it is phentolamine. Now, coming to chloramphenicol, this is what is important. Chloramphenicol will cause grey baby syndrome. All of you must remember this. It will cause grey baby syndrome. Colors are really important. They will ask you. Purple toe syndrome, I told you. Yes, it is warfarin. Purple glove syndrome, phenytoin. Grey baby syndrome, this is chloramphenicol. Fluoromutilins, it is lefamulin. The side effect is QT prolongation. It will cause QT prolongation. That's all. So, we are done with protein synthesis inhibitors as well. Next, what is left? These are anti-folate drugs. Anti-folate drugs. Now, How is the active form of folic acid formed? Yes, pteridine plus PABA will combine together to form DHFA, and DHFA will form tetrahydrofolate or folinic acid. This is the active form. For formation of this, you need DHPS enzyme and DHFR enzyme. DHPS, S for S, can be blocked by sulfonamides. DHFR will be blocked by drugs like methotrexate, trimethoprim, pyrimethamine. How do you remember this? Remember this as MTP. Why? If you block DHFR, what will happen? Folic acid will reduce. If folic acid will reduce, what will happen? It will cause neural tube defects. If there is neural tube defects, what will you do? MTP. That is why remember it as MTP. Methotrexate, trimethoprim and pyrimethamine. That's all. Now, sulfonamides, we have silver sulfadiazine. This is drug of choice in burns. Yes, diazine means diya, lights. When you go too near to the lights, it will burn yourself. So, silver sulfadiazine can be used in burns. How to remember sulfonamides? All of them will have sulfa in their name. Sulfadoxin, sulfdiazoxin, sulfoxamethasone. All of these are having the name sulfa in them. These are sulfonamides. Now, dapsone. Dapsone is also a sulfonamide, but it does not have sulfa in the name. This is what I want you to remember, dapsone. Dapsone is drug of choice in leprosy as well as dermatitis herpetiformis. Dermatitis herpetiformis. Now, what is the side effect of this? The side effects of this, the most important things to remember are, it can cause kernicterus. It can cause kernicterus. It can also cause SLE. Which SLE? Drug-induced SLE. Drug-induced SLE. I already talked about this in the general pharmacology chapter. Any drugs that are undergoing slow acetylation, in these slow acetylators will cause drug-induced SLE. I call them as SHIP drugs. Now, coming to DHFR blockers, we have methotrexate, trimethoprim and pyrimethamine. Since it is decreasing the folic acid, it will cause neural tube defects. Now, what is the drug of choice for toxoplasmosis? Drug of choice for toxoplasmosis, it is sulfadiazine plus pyrimethamine. Pyrimethamine. This is the drug of choice. But in pregnancy, you cannot give this because they are contraindicated. In pregnancy, you will give spiramycin. Spiramycin. Now, there is something known as cotrimoxazole. Yes. Now, here you mix two drugs. Which two drugs? See here, trime or trim. You are mixing trimethoprim. You are mixing trimethoprim with oxazole. This is sulfamethoxazole. Yes, sulfoxazole. So, you are mixing both of them and it will form cotrimoxazole. That is what is given. Co means two drugs are combined together. When two drugs will combine together, it will cause sidal effect. Yes, so this is the only drug that is having sidal effect in the antifolate. That is what is cotrimoxazole. Cotrimoxazole is sidal. This is one exception. Aminoglycoside is sidal in protein synthesis inhibitor. Okay. Now, coming to the last class, that is DNA guidase inhibitors. So, if we block DNA guidase inhibitors, the replication is not happening. The DNA will die and the cell will die. Got it? So, here the drug names are fluoroquinolones. These drugs are fluoroquinolones. How will you call them? These are fluoxacins given in the name. Fluorofluoxacins. Yes, what are respiratory fluoroquinolones that you must know? These are levofloxacin, moxifloxacin and gemifloxacin. These are very important. Okay. Now, ciprofloxacin is the drug of choice for prophylaxis of meningococcal meningitis. What is the drug of choice for empirical treatment? Empirical treatment is ceftriaxone. Okay. But in pregnancy, you cannot give ciprofloxacin because it is contraindicated. So, again in pregnancy, you will give ceftriaxone even for prophylaxis. Yes. Now, what are the side effects of fluoroquinolones? You can remember it with the help of PQRST. Yes. P for peripheral neuropathy. Q for QT prolongation. Yes. R for rash. S for seizures. T for tendinitis. It can cause inflammation of tendons. Yes. So, that's all. Maximum QT prolongation and maximum seizure risk is seen with moxifloxacin, M for M. Yes, please remember this. And MTP, moxi, trova and pfloxacin, these are safe in renal failure. Renal failure. You can see here at the end I have given you antibacterials that are safe in pregnancy. What is the most safe drug in pregnancy? It is PCM. So you can remember it that way. These are penicillins, cephalosporins and macrolides. Macrolides are also alternative to penicillins. What are the antibacterials that are safe in renal failure? All of them I have given. We have discussed two most important ones, ceftriaxone and cefoperazone. Clindamycin also. All of them are secreted through bile. At least remember these three. These are safe in renal failure. Got it? Safe in pregnancy are PCM, penicillins, cephalosporins and macrolides. Yes. So now we are starting with the TB treatment. Now the regimen of TB is HRZE for 2 months, HRE for 4 months. Now why are we excluding Z, that is pyrazinamide, for the next 4 months? Because this is very hepatotoxic. That is why we give it only for 2 months. Did you understand this? So this is the basic treatment of TB. So you see here, H is for isoniazid, R is for rifampicin, Z is for pyrazinamide, E is for ethambutol. What is important here? The side effects are very important. Now, first we will start with the isoniazid. It will block the mycolic acid synthesis. Okay. Now, we will have resistance to isoniazid if CATG gene is reduced. CATG gene is reduced, we will have resistance. Please remember this. Now, isoniazid will decrease vitamin B6. That is also known as pyridoxine. That is also known as pyridoxine. Because there is reduction in pyridoxine, it will cause something known as peripheral neuropathy. Yes, it can cause memory issues. It might even cause seizures. So these are the side effects I want you to remember with isoniazid. How can you remember pyridoxine? See, iso means isolated person. For isolated person, what do you don't have? See, pyri means pyar. Isolated person ko pyar nahi milte. This is how you can easily remember isoniazid. The pyridoxine is getting reduced. Because of this, he is having peripheral neuropathy, memory issues and sometimes seizures as well. Now, coming to rifampicin. Rifampicin, remember the secretions. It will cause orange secretions. Yes, there will be orange tears, orange urine. Yes, all of these are seen with rifampicin. It is also an enzyme inducer. If it is an enzyme inducer, what will it do? It will cause a drug failure. That is what we have studied in G Pharma. Yes. Now, coming to pyrazinamide, I have already told you it is hepatotoxic. Now, ethambutol, E for E, it will cause eye problems. That means it might cause optic neuritis. It will also cause color blindness. Which color blindness will it cause? It will cause red-green blindness, red-green color blindness. That's all. Now, there is something known as MDR-TB. MDR-TB means multi-drug resistant TB. Here, the person is resistant to both isoniazid and rifampicin. And if the person is more than 14 years of age and if he is having MDR-TB, we will give a regimen that is known as B-PALM regimen. B-PALM regimen. This is very important. B for bedaquiline, PA for pretomanid, L for linezolid, M for moxifloxacin. At least remember bedaquiline. This is where the questions are most commonly asked. Q for Q, it will cause QT prolongation. Now, it works by blocking the mycobacterial ATP synthesis. These are the questions that have been asked on bedaquiline. Very important to remember. L for linezolid. M for moxifloxacin. PA for pretomanid. This is what I want you to remember. Now, coming to leprosy. How do I remember the drugs in leprosy? I recall it like this. I study a line called leprosy is a recurrent and chronic disease. Yes. See, R for rifampicin. C for clofazimine. D for dapsone. What is the drug of choice in leprosy? It is dapsone. Now, we have two kinds of leprosy, paucibacillary and multibacillary. For paucibacillary, you have to treat for 6 months. For multibacillary, you have to treat for 1 year. Now, what is the exact treatment? We will see. First, you have to give rifampicin and clofazimine. So, remember one dose, 600 mg for rifampicin, you divide by 2, it will become 300 for clofazimine. Okay. So, rifampicin 600, and clofazimine 300. You have to give it to the patient in front of you. He has to take those tablets in front of you. Yes, that is what is known as supervised. So you give it once, okay, in the first day of the month. Now after that he goes back home and he takes dapsone and clofazimine. Dapsone and clofazimine. Again remember 100 mg, 100 by 2 is 50. Okay, dapsone and clofazimine. Now he takes this daily for 28 days. For 28 days. That's all. 1 month is done. 1 day he is taking supervised therapy, 28 days he is taking unsupervised therapy. So this is 1 month treatment. Now if a person is having paucibacillary, he should do it for 6 months. If a person is having multibacillary, he should do it for 12 months. That's all. Now what is the drug of choice for lepra reaction? These are steroids. These are steroids. That's all. Now coming to the fungals, antifungals. What is most important in antifungals is a drug called amphotericin B. Is a drug called amphotericin B. We will talk about this. See, amphotericin B works by blocking the or breaking the cell membrane. How does it break? It binds to something known as ergosterol. Cell membrane of fungus will have ergosterol. It will bind to ergosterol. It will form a pore, and because of these pores, the cell will die. This is what is amphotericin B. Okay. Now there are many other antifungals, but for the exam, please remember amphotericin B. Now let us see this. Now a person who was happy before has been diagnosed now with AIDS. So obviously he got unhappy. You can see in the image. Now when the doctor checked the CD4 counts, his CD4 counts are less than 100. So he thought he might get TB and he has started him on INH prophylaxis. What is the meaning of INH? It is isoniazid. Now since he is sad, he went to a park, he is sitting there. Now he started seeing pigeons and he started feeding all these pigeons. Now after this, he started having fever, headache and neck rigidity for more than 2 weeks. Yes, he waited for 2 weeks, it did not reduce. So he understood there is something wrong and he went to Kasturba Medical College, that is KMC. That is KMC. Once in KMC, they have understood that the person is having meningitis. And once they have done the CSF sample, this is how it is looking. Look carefully, this is a spotter image. Everything that I told you is a question. Yes, it is India ink stain. It is India ink stain. It is India ink stain. What do you see here? Encapsulated budding yeasts. Encapsulated budding yeast. Did you understand this much? Now, what is this? What is the most common cause of meningitis in HIV? You should have known the answer. If you don't know what is this India ink staining, it is because of an organism called Cryptococcus neoformans. So the most common meningitis in HIV is cryptococcal meningitis. What is the drug of choice for cryptococcal meningitis or Cryptococcus neoformans? It is IV amphotericin B. IV amphotericin B plus flucytosine. Flucytosine. You have to give both of them. After this, it should be followed by fluconazole. Fluconazole. This is the entire treatment for Cryptococcus neoformans. Now, what is important to us is IV amphotericin B. So you write here the drug of choice is IV amphotericin B. Now, how does this act? It binds to the ergosterol and forms pores on the cell membrane. The drug of choice. This is the amphotericin B is the drug of choice in which conditions? It is drug of choice in Kala-Azar, mucormycosis. Yes, you might have seen this so many times after the COVID. People are using amphotericin B and Cryptococcus. That is what we have just studied. So if you see the story, remember this carefully. KMC. KMC is the drug of choice. K means Kala-Azar, M means mucormycosis, C for Cryptococcus. That's all. Now, what are the side effects of this? It will cause infusion reactions. It will cause infusion reactions. Again, nephrotoxicity and hypokalemia. This is how you can remember INH. You see here INH. So everything in the story is important. How do you get Cryptococcus neoformans? From pigeon droppings. You can see pigeon droppings here. If a person is having AIDS, he can have TB. So he started on INS prophylaxis. Yes, the most common cause of meningitis in HIV is Cryptococcus neoformans. In this we do India ink staining. All of these are questions, PYQs. Yes. Now, How do you prevent this nephrotoxicity? Obviously, you can preload the patient with saline. You can give 1 to 2 liter of normal saline. If this is not working, then you change amphotericin B. You don't give amphotericin B, you give liposomal amphotericin B. Liposomal amphotericin B. Yes, this is nephrosafe, renal safe. Now, coming to the viruses, we are finished with the fungals. Coming to the viruses, the most important one is HIV. When a person has HIV, what is the treatment? It is HART. It is antiretroviral therapy. Now, in any patient, you have to give HART lifelong. You have to treat them for their entire life. How do you treat HIV? See, you have to limit the HIV now. So, I remember it as limited, LTD. Now, if a person is more than 10 years, what are LTD drugs? It is lamivudine, tenofovir and dolutegravir. Lamivudine, tenofovir and dolutegravir. Now, if an infant is born to HIV mother, to prevent the perinatal transmission or vertical transmission, what drugs will you give? If a baby is at low risk means the mother is already taking ART, so the baby is low risk of getting the HIV. So in this baby, you will give syrup nevirapine. Now, if the baby is at high risk, that means the mother is not using any ART, the baby is at high risk of getting HIV. So in this patient, you will use syrup nevirapine along with zidovudine. You have to give zidovudine as well. Let us suppose if the baby's mother is already exposed to nevirapine, that means she has used nevirapine before, then you will give zidovudine. These are the most important things about the treatment of HIV. Now, coming to post-exposure prophylaxis, let us suppose somebody has drawn blood from the HIV patient and with that needle you got pricked. That is what is known as needle prick injury. Or if there is any needle prick injury, what you should do? You should start LTD treatment within 1 month. You should start LTD treatment for 1 month. Yes, LTD you already know, lamivudine, tenofovir, dolutegravir. You have to give it for 1 month. But when should you start this? You should start this within 2 to 72 hours of exposure. As soon as the needle prick injury happens, within 72 hours, you have to start LTD and you should use it for 1 month and get it tested for HIV. Now, HIV with TB. What should you treat first? You should treat TB first always. ATT is first, then you should treat AR. Did you understand this much? Now, why not ART? If we treat HIV first, it will cause something known as IRIS. Immune reconstitution inflammatory syndrome. This is what is happening. Now, coming to the anti-protozoal drugs. In this, the most important one is malaria. We have 2 kinds of malaria, uncomplicated and complicated. See, in severe or complicated malaria, the drug of choice is simple. It is IV artesunate. That means there is brain involvement, there are seizures and stuff. This is what is complicated or severe malaria. Coming to uncomplicated malaria. In India, it can be caused either due to Vivax or falciparum. Now, in Vivax, what is the treatment? It is chloroquine. In adults, what about pregnancy? It is also chloroquine because it is safe in pregnancy as well. Now, coming back to falciparum, it is ACT. ACT means artemisinin combination therapy, but this is not safe in pregnancy. That is why in the first trimester, you cannot give ACT. So, what will you give? You will give quinine plus clindamycin. Second and third trimester, organogenesis has already happened, so you can still give ACT. So, how do you remember all of it? See, how do you clear a viva? By answering it correctly. Yes, so viva is cleared by facts. So, this is how I remember. Viva means Vivax, C is for chloroquine. So, Vivax is chloroquine. Facts. F is for falciparum and ACT is for ACT therapy. So, falciparum, ACT therapy, Vivax, chloroquine. That's all. Done. Now, coming to the ACT therapy. How do you give ACT therapy? ACT therapy, in northeastern states, you give artemether and lumefantrine. We can call it as NEEL. Northeastern states, artemether, lumefantrine. In rest of Indian states, rest of all the other states, you will give artesunate, sulfadoxine plus pyrimethamine. If you remember, sulfadoxine plus pyrimethamine plus artesunate is the ACT therapy. Yes, if you remember from the previous thing, we have studied sulfadiazine plus pyrimethamine is for toxoplasmosis. Here it is sulfadoxine plus pyrimethamine. Yes. So, rest of India you can remember it as ASP. It is ASP. That's all. So, for prophylaxis, what should you do? For prophylaxis, if the person is traveling for less than 6 weeks, you should give doxycycline. If the person is traveling for more than 6 weeks or 6 weeks, you should give mefloquine. Why? Doxycycline has to be given daily, mefloquine can be given weekly. That is the reason why for long-term travel we use mefloquine. Now, how do you give this? Before the travel, you have to give at least 2 doses and you have to continue throughout the travel. After coming back also, you should treat them for 4 weeks. That's all about malaria. Now, coming back to amoebiasis. In any symptomatic cases of amoebiasis that is due to entamoeba histolytica, you will give something known as metronidazole. Metronidazole is nitroimidazole. So, we are going to see metronidazole here. Now, metronidazole, you can see this is the mnemonic for all the uses of metronidazole. Go get in a metro. When you see a metro, go get in a metro. See, G for go. It is Giardia. Another G, it is Gardnerella vaginalis. It will cause a bacterial vaginosis. Very important question from your gynecology. Bacterial vaginosis, Amsel's criteria, clue cells, all of this. Yes. Get E for entamoeba histolytica. This we already talked. It is amoebiasis. T for trichomoniasis. It will cause a strawberry cervix. Now, IN, A, infradiaphragmatic anaerobes. For supradiaphragmatic anaerobes, the drug of choice is clindamycin. For infradiaphragmatic, it is metronidazole. I told you the most important side effect of metronidazole, what is it? It is going to be disulfiram reaction. That's all about amoebiasis. Now, only one thing is left, that is antihelminths. Most common one I want to say is platyhelminths. What are platyhelminths? See here, for platyhelminths, the drug of choice is praziquantel. At least remember this much, praziquantel. Yes, for the remaining ones, it is albendazole. Neoplasia. This is the last chapter. So, what is neoplasm? Neoplasm is uncontrolled cell division. It is uncontrolled cell division. So, there are a lot of cell divisions happening. So, there are increased number of cells forming a mass. That is what is tumor. No, that is what is neoplasm. So, how can you treat this? When there is increased cells, you have to kill these cells. That is what is known as cytotoxic drugs. So, you are giving drugs to kill these excess cells. Now, how does cytotoxic drugs act? It will kill all rapidly dividing cells. So, if you see carefully, it will kill the tumor cells, yes, because it is uncontrolled cell divisions. But the issue here is, in the body also, we have rapidly dividing cells, normal cells. It will kill those cells too. That is the issue. So, if you see here, what are the common side effects of the cytotoxic drugs? It will kill the rapidly dividing cells in the body. These are present in bone marrow because they make RBC, WBC and platelets. Now, when these cells are killed, what will happen? RBC will decrease, it will cause anemia. Yes, WBC will decrease, it will cause leukopenia. Platelets will decrease, it will cause thrombocytopenia. This is what is known as pancytopenia. Hair is also a rapidly dividing structure, so it will cause hair loss. And GIT also has a lot of rapidly dividing cells. When we kill GIT cells, it will cause mucositis. Because of this, absorption doesn't happen and it will cause diarrhea. And enterochromaffin like cells will be dead, and this will cause what? Release of histamines and serotonin. When serotonin increases, it will cause nausea and vomiting. Okay. Now, coming to the cells, when there is lot of cell death, it will release purines, and purines will be converted into xanthines to uric acid. So, there will be hyperuricemia. So this is what you see in all of the cytotoxic drugs. That is why we have made targeted anti-cancer therapy. This is the second class of drugs, targeted anti-cancer drugs. So we have cytotoxic drugs, targeted anti-cancer drugs. These will have lesser side effects in comparison to cytotoxic drugs. But for the exam, only the side effects are important. So we are going to do the side effects first. Yes. So if a person has anemia, what should you do? We talked about this in the heme chapter. What should you give? You should give erythropoietin analog. Yes, what will you give? It is darbepoetin or epoetin. Darbepoetin or epoetin. If a person has neutropenia, what should you give? GCF or GMCF? These are filgrastim, that is GCF, sargramostim, that is GMCF, that is GMCSF, colony stimulating factor. This is granulocyte colony stimulating factor. Granulocyte, G for G. Thrombocytopenia, I told interleukin 11 analog, that is oprelvekin. Oprelvekin. Hyperuricemia, what will you do? You can give rasburicase to decrease the uric acid that is already present. To prevent the formation of uric acid, you will give allopurinol. That's all. Now, coming to the side effects. Let us suppose this is one person who had cancer. If a person has cancer, obviously he'll be sad. Yes, he's sad. Right. Now, we'll draw the other structures of this man. These are his ears. These are his kidneys. Yes. Now, I'm drawing the lungs. Now, I'm drawing his heart. Look carefully how am I drawing his heart. I'm keeping one D, next T and an inverted T. You got 4 chambers. Yes. Now, I'm drawing his bladder. You see carefully, this is the bladder and there is urine. Okay. These are all the side effects you need to remember. Right. First we will see. C for cisplatin. C for cisplatin. C for cisplatin. You can see C here in the ears, C in the kidneys and even in the mouth. Yes, I have written C like this, even in the mouth. So what is it causing? It is causing ototoxicity, nephrotoxicity, and it will cause maximum nausea and vomiting. It will cause maximum nausea and vomiting. Okay. Now, see here, this is B. B for bleomycin, busulfan. Both of them will together cause, what is it? These are lungs, it is causing ILD, interstitial lung disease, pulmonary fibrosis. Amiodarone also causes this. We talked about it. Methotrexate also causes this. Yes. Now, coming to the heart. How did I draw the heart? D and T. D for doxorubicin and daunorubicin. Doxorubicin and daunorubicin. T for trastuzumab. T for trastuzumab. All of these will cause cardiotoxicity. Which cardiotoxicity will it cause? It will cause dilated cardiomyopathy. Dilated cardiomyopathy. So we are done with this also. In the bladder, how did I draw the bladder? It is a circle, no? So I call it cycle. It is cyclophosphamide. Cyclophosphamide. And you can see urine, how is it there? It is an I. Cyclophosphamide, I-phosphamide. I-phosphamide. I have drawn the urine red in color. So the person is having cystitis. It is hemorrhagic cystitis. It is hemorrhagic cystitis. That's all. These are the important side effects that you need to remember. Now, what else is there? Bleomycin can also cause flagellate dermatitis. Bleomycin can also cause flagellate dermatitis. Okay. You can see the peripheries, they are in the shape of V. Yes, V for the peripheries. So V for V, vincristin and vinblastine also will cause peripheral neuropathy. Will also cause peripheral neuropathy. And then there is one peculiar syndrome which will cause a desquamation of hands and foot. Hands and foot. Hands and foot. Hands and foot desquamation is known as hand-foot syndrome, hand and foot syndrome. Desquamation means peeling of skin, hand and foot syndrome. If the skin is being peeled off, you will get frustrated. When you are frustrated, what would you say? See, it is given on the screen. Yes, this is 5-fluorouracil. This is 5-fluorouracil. Did you understand? 5-fluorouracil and capecitabine. So these two drugs will cause hand and foot syndrome. These are the side effects I wanted to remember from this chemo man. Now, if a person has vomiting, how will you treat him? Obviously, you will give ondansetron if it is early onset. Early onset means the vomiting is happening within 24 hours of starting the drugs. You will give ondansetron. Ondansetron. If it is more than 24 hours, that is late onset. Late means more than 24 hours. In this, you will give aprepitant. You will give aprepitant. For nephrotoxicity, you can prevent it by giving a drug called amifostin. Hemorrhagic cystitis can be prevented by giving a drug called Mesna, but you can treat it with steroids. Cardiotoxicity can be prevented by a drug called dexrazoxane. Dexrazoxane. That's all. These are the drugs that you can give for these side effects. Yes. So we are done with the rapid revision. I hope you understood all of this. Yes. Please revise all of this. You'll be able to score well in the exam and answer most of the questions. Yes. Thank you.